Please help me welcome Dr. Soroush Zaghi.
Thank you. Thank you, everyone. It is so great to be here with you at the Breathe and Thrive conference here in Las Vegas. Amazing to have you guys here. Show of hands, who here has been coming to the ALSC conferences in the past? And who here is new? Who's here new to these seminars? Welcome, welcome. Terrific to have you. And another show of hands, who here has heard me speak at least one time before? Excellent. And who here is kind of new to these topics? All right. So this lecture that we give at ALSC is one of my favorite because I go really advanced. All right. So this is an advanced group. And over the years, we've made some really cool discoveries together here in this room. And I hope that this year will be another one where we have a lot of discussion and dialogue and really take it to the next level. For those of you who want a copy of the lecture slides, go ahead and either scan this QR code or take a picture, and you'll get access to all of the slides that I'll be discussing today. And as always, feel free to share pictures, videos, whatever you guys like. You guys are welcome to use the slide content. However, we just request that you put slide credit, Dr. Soroush Zaghi, the Breathe Institute, so that we can maintain the copyrights to the photos and videos and images that are presented. Otherwise, we hope that you enjoy the seminar. My name is Dr. Soroush Zaghi. I'm a graduate of Harvard Medical School, UCLA ENT residency, and Stanford Sleep Surgery Fellowship. And I like to start my slides with this quote from my first day of medical school. And those of you who have heard me speak routinely see me putting up this slide. And this slide is more important for this lecture that we will talk about today than perhaps any other. And this is the reality that half of what you learn in medical school, dental school, speech therapy school, dental hygiene school, physical therapy school, orthodontic school, will be shown to be either dead wrong or out of date within 5 years of your graduation. Who here agrees with that statement? Who here has seen it with their own two eyes, that the information that we learn in school is quickly being outdated? The trouble is that nobody can tell you which half, so the most important thing is to learn how to learn on your own. And that is why it is so important to always keep learning, keep observing, keep wondering. Because the greatest enemy of knowledge is the illusion that you already know everything. And it's really with this mindset that we plan this conference and we plan our research. It's the focus that, oh my goodness, there's so much more to learn. And I really have to thank my amazing clinical research team behind the scenes with Laylee, Chad, Sandra Luz, Leslie. We have Jen here and Rhiannon. It's fantastic to have all of you guys here, and thank you guys so much for all the work that you guys do that allows us to be possible. So big round of applause for them. The research work that we do, each publication takes maybe 3 to 5 years to bring to inception. I'm going to teach you guys today how to think of a good research study and how to execute it. Oftentimes the first step is an IRB application, and oh my goodness, how much work is that? So thank you to Leslie and Laylee for taking the lead on that. And then there's the execution of the study, the data collection, the writing process, submitting it for publication. So it's really a lot of work, and I couldn't do it without my amazing team. In 2020, I had the honor of coming here to the ALSC and talking about our 2019 paper at the time, talking about the technique, the scissors and sutures technique. We talked about TR, MAR, TIP, and LPS. And I hope that we kind of take these things for granted now, is that right? But to think that this was only 5 or 6 years ago. In 2022, we really got deep in there with the anatomy. We have the advanced laser settings. Who here is using our laser settings? The fascia, genioglossus, good settings, right? Deep fascia. Wow, what a breakthrough in its own right. And back then I was starting to talk about the intermolar distance and tongue space. In 2023 we came and we did a live demonstration of soft palate remodeling. Who here started doing the soft palate remodeling in their offices? Awesome. 2024, we started talking about advanced wound healing in terms of serapeptase and Kenalog. and we introduced this concept of mid-tongue restriction. Who was here when we settled on that term? Who was here? Remember how we went through and we said, what should we call it? What do you guys think? Should we call it, cupping? Should we call it dimpling? Should we call it, posterior tongue tie, mid-tongue restriction? And now we have, many publications, including the 2025 summary, as well as our recent paper that has now brought this terminology to life in terms of, clarifying the concept of posterior tongue tie into mid-tongue restriction. And so the question is what ideas will 2026 be remembered for? And it's exciting to think of all the history that we make when we all come together and share ideas. And so to that extent, I really want to welcome you guys, and I want to thank you guys for being here, because some of the concepts I'll talk about are new, and this is my peer review process. My peer review process is not submitting it to journal editors who have no understanding, but rather it's you here in the audience. So if you have experience of your own that relates to some of the things that I talk about, I absolutely welcome that, because that is exactly how we develop and advance clinical knowledge. So do you guys remember this? Tongue tie, tongue tone, and tongue space. You guys remember that? Who loves that? How cute is that, right? Tongue tie, tongue tone, tongue space. But starting today, we're going to change that. Is it okay if we change some things? We're going to change it. So it's going to be tongue tie, tongue tone, tongue space, and one more element. One more element. And this element is hypermobility. Hypermobility. Wow. The missing clinical variable. All right? Because what we're trying to do is put the pieces of the puzzle together. How awesome is this figure, by the way? Is this a fun figure? Big thank you to Chad here. It's so creative for putting that in there. So the way it works in our clinic is I tell Laylee, what I want, what I'm looking for, and then they just execute. So I love it, and we'll make history with this. But who here, first of all, has seen that when you add myofunctional therapy to tongue tie, you get better results? Show of hands? For sure, right? For sure. And who here's seen that, hey, tongue space is a real problem? Yes? Absolutely, without a question. Well, I'm here to tell you there's one more variable that just stumps you sometimes. And it's like, what is going on? Why is my formula for success not working for this case? And that case is with patients who have problems with hypermobility, collagen disorders. And this can affect 10 to 20% of the general population, with 5% of patients being severely affected. And so when patients come to us and we're treating them and we're getting 90% success, it's often a big question mark. What's causing this person's TMJ issues, their forward head posture, their narrow palate? And to that extent, I hope that you guys are excited to talk about this and to talk about the evolution of knowledge. As we go through this process, it's important to maintain perspective. And what that means is that you can see things from different vantage points, right? If you're looking at something and you're trying to see 4 objects, you'll be able to see 4. But if you're only limited and you just don't quite understand it yet, all you'll see is 3. And this is so true about advanced knowledge. So if you're used to tongue tie, tongue tone, tongue space, it may be a little bit challenging at first, but I'm going to show you here why it's important, how easy it is, and how rewarding it can be to serve these patients. Who here has seen hypermobile patients in their practices before? Here's just a few are looking for, right? How many people are actually screening for it in their clinics? Just a handful. So when I come back next year, it'll be everyone in the audience, and you guys will see this, and you guys will do seminars on it, and it'll be really awesome for you guys. All right, so how do we develop new knowledge, right? Like a brand new idea. How do you get a brand new idea? And how do you make that into research that you publish on? It all comes from an idea, from an observation, right? A suggestion, something someone says in a seminar. And so I really love hanging out with Richard. He's just a cool buddy. We hanging out, talking. We went to Switzerland together a couple weeks ago, and he's just so interesting, right? And he just thinks, and he really thinks out of the box. So he calls me up one day, and he's like, "Hey, Soroush, there's this thing called dimethyl sulfoxide. Who's heard about this? Okay, you guys use it? What do you know about it? What do you know about it? Yeah, so it's like an organic solvent. Anyone use on daily practice? So Richard tells me that this cures blindness. I mean, that's bold, right? He said that you could put this in someone's eye and it cures blindness. It's good for healing. So let's start using it on the tongue. What's your reaction to that? Who here thinks it's brilliant? Who here thinks it's a little crazy? A little crazy? All right. So but what if he's right? What if he's right? All right. So what are the steps I'm going to take? Richard Baxter tells me that dimethyl sulfoxide can cure blindness, and maybe we should try it on the tongue. What's the next step? All right, so you do a little literature review, right? Hey, let's look up some PubMed. What's it used for? Has it ever been used? No, it's never been used on the tongue. It's never been used on the tongue. Do we give up? It's never been used. You don't know. And remember, lack of evidence is not evidence. So just because there's no evidence saying that this random organic solvent doesn't work, doesn't mean it doesn't work. It just means you don't know, right? And so I'm bringing up this example not to convince you guys to use it, because I did the research and it doesn't work, and it's a little harmful, okay? Because you can inhale it and it irritates the lungs. But I'm just telling you and showing you all the work that goes into developing a new idea. And the way that we develop new ideas is with an evidence-based approach, okay? So Richard Baxter says this product can, cure blindness. There's no randomized control trials. So do we give up? Do we say that just because there's no randomized control trials it doesn't work? No, that's not where new ideas come from. New ideas come from case reports, case series, observations. This is how new knowledge emerges. Okay? You observe something, like, wow, I am seeing this, and this is crazy. It's so interesting. All right? You write it up, you present it at a conference like this, you get feedback, and you see 1 case, 2 cases, 3 cases, 4 cases, 10 cases. Now you want to write it up into a case series. Now you really have something that other people can learn about. And you turn that case series into a cohort study, maybe 50 to 100, and then you do a randomized controlled trial. You're not going to do a randomized controlled trial on day 1 for something you have no idea about because you don't understand all of the variables. And so this is how we advance the knowledge, okay? An observation, new ideas, but that's not enough. You actually have to test it. And the testing can sometimes be a little risky, and like, how do you test something new? And how do you stay ethical within those boundaries? So I had a patient who just showed up to my clinic one day. It was Michelle Murdy. And she said that she was in a conference by Dr. Baxter, and he mentioned this, and she wants to volunteer for this experiment. She wants to volunteer. She was post-frenuloplasty, and instead of Kenalog or serapeptase, she wants to try this. So we do informed consent, and here we go. Let's watch this experiment. Tribute to my friend, Dr. Richard Baxter. He found this random lab chemical called dimethyl sulfoxide. I've never heard of it, okay? But this is showing you my interest in research, and this is how you do research, okay? First of all, I've never ever heard of this. I'm observing it. I looked online. It seems safe based on what I saw online. So we have a willing patient here. Here's a willing patient. Come around. And just say to the camera that you are a willing patient.
I am a willing patient.
This is entirely experimental, investigational, and we have no idea what this is going to do.
Correct, what he said.
All right, and we blame or congratulate Dr. Baxter for the outcome of this research.
Okay.
Open up for me.
Okay.
And we're just going to apply it there and watch if she survives or not. All right. Let's get a little bit more in there. Did it even go? No, it didn't. Okay.
Mm-hmm.
In there. All right, close your mouth. Mm-hmm. Okay, this is just a little safety test.
Ooh.
Is it terrible? Mm-hmm. Open. It tastes bad?
Mm-hmm. Tastes like...
Does it burn?
Tastes like how gasoline smells.
Does it burn?
No, it just...
Okay.
Oh, I don't want to swallow it.
Don't swallow it. We'll have your wife out. Lift up again. Good. We're going to do a little bit more to find the rate-limiting dose, okay? The rate-limiting dose means how much you can give before you have a toxic effect, okay?
Okay.
So that is what we are here to investigate.
Uh-huh.
And let's see if we get a rate-limiting dose here. Close your mouth. All right. Let's check your vital signs and see. Open up your mouth. Open up. You good? Lift up. You doing okay? Up to the front of your teeth. All right. So we have established the safety of this product. Okay. We know that it is non-lethal, and we're going to see if it's toxic in any capacity. And now we feel safe applying it. And so we can tell the patient, all right, why don't you try it once a day over the course of a week and let us know what you think. This is how research is done. And let's see if we discover something new. All right, so this is a joke, right? But I hope you guys appreciate that. But I hope you guys are a little entertained by it, right? Okay, because it's here to teach you a lesson of how we come up with new ideas, the risk that it takes, the observation, and what it takes for a product to succeed. And so one of the first things is, safety, efficacy, patient tolerability. So this product right off the bat, it smells like gasoline. It's not very patient tolerable. She tried it, made her cough a little bit. And so, all right, we have a case report. We tried it once. Not so hot, not the best thing. So I'll kind of leave it at that. Now, if someone else wants to try it, someone else feels inspired, and they go home and they're like, wow, it super loosened it. Now we're comparing case reports. Maybe we get a case series. And that's how we develop new ideas. That's how we discovered Kenalog, for example, or that's how, serapeptase, all these things. It just comes from like a few case reports, trial and error to figure out what's what. So that's research. Research is systematic investigation of observations. You got to look at something in the real world to establish facts and reach new conclusions. Research isn't just going through the literature and summarizing the literature and doing a literature review or a systematic review or setting up guidelines or opinion papers. It's not new research. And it's with that kind of approach that I want to start the lecture here today. What we're going to talk about in the lecture is how did myofunctional therapy come to exist, right? Who here practices myofunctional therapy, a therapist here, right? Don't you guys want to know the history of your profession? Okay, like where did it come from? How did this idea become established to the point where you have courses and seminars and patients are coming to you and paying you for this service? I'll talk to you guys about how we developed our Zaghi functional frenuloplasty protocol. I'll tell you how we've updated it with refined techniques and endpoints, and how we're advancing things by looking at hypermobility, red light therapies, serapeptase, Kenalog, and more. And to really appreciate this, we have to establish systems thinking. Systems thinking is different than linear thinking. Linear thinking means you do X, you do this one thing, like you turn on the light and the light turns on, okay? It's like one-to-one. But medicine, clinical medicine, functional medicine isn't one-to-one. There's a lot of different variables involved. And so you really have to have like a systems thinking, really open mindset and understand how all the pieces of the puzzle relate. The problem with a lot of the pitfalls from a lot of the adversaries is the linear thinking. And so when you're talking to someone and they're saying, oh, where's the evidence, or I haven't heard that, you'll explain to them that, hey, what you're asking for is very linear thinking. And in functional medicine, in body work, in myofunctional, we're looking at it as a whole system. And we really have to understand it from a systems thinking perspective. Not only one intervention, but all of the interventions here together. So we start with case reports, case control, cohort, randomized control, and then go to systematic reviews. But really the first step is the observation. It's what you guys are seeing, and then testing that and getting results. And the results are excellent, but what's more important is the discussion with your peers, right? You can't be married to what the results say. You have to take that extra step to come up with analysis and thinking, and I hope that we'll have some discussion here today that will lead to new ideas. We talk about the impact of tongue-tie and restricted tongue mobility. The tongue is required for optimal speech, chewing, swallow, oral hygiene, and posture, but also for sleep, breathing, and upper airway development. Yet we understand that tongue-tie is only one piece of the puzzle. In the past, we've talked about tongue tone, tongue tie, and tongue space, and we're so excited that now we're also discussing this in the context of hypermobility. All right, we'll play this video one more time for you guys. So say it with me, tongue tie, tongue tone, tongue space, and hypermobility. All right. Because what we want is a functional approach to sleep and breathing. We're not here just to treat tongue tie. We're here to help take care of patients, to optimize health and wellness for all patients. So when it comes to tongue tie, when it comes to health, it's really a two-way street between anatomy and physiology. There's form and there's function. Who here works on the form? Who here works on palate expansion, tongue tie releases, things like that? Who here works on the function? That's body work, myofunctional, excellent, all right? And, form and function. Which one comes first? And I get this question all the time. Should we do the release first or the expansion first? All right, who here thinks expansion? Who here thinks tongue tie? All right, well, it really depends. It really depends, right? It really depends. But it's really important to kind of break things down into, this dynamic between the form and function. When we're talking about function, we want tongue up, lips closed, healthy breathing through the nose, and recognizing that chewing and swallowing are needed to grow. When the tongue is up, it helps to shape and develop the way our faces and airways grow. The tongue should rest at the roof of the palate. But if you have a tongue tie, if you have low muscle tone, if you have problems with hypermobility, or if you have tongue space, all of these can interfere with high tongue posture. So if the goal is to get the tongue up, it's not just the tongue tie. It's the myofunctional, the tongue space, and the hypermobility aspects. We do have to recognize that inadequate tongue space is a cause of low tongue posture, and some patients, after doing a palate expander, their tongue goes up. Who here has seen that? You guys see that on the CT scans? For sure, I'm seeing a lot of nods. Dr. Guilleminault described the Guilleminault musculoskeletal hypothesis. I have a little echo in the sound. I don't know if you guys can do anything about it. Maybe because this one's on, or I don't know if you can bring the volume down. I'd appreciate it. So Dr. Guilleminault talked about the musculoskeletal hypothesis. He said that there's something, whether it's systemic inflammation, posture maladaptation, or unhealthy facial growth, that leads to mouth breathing. The mouth breathing leads to increased inflammation, tonsil enlargement, and worsening of the nasal breathing. And really, this is a cycle, such that the diet or the environment, the function, affects the form. You get big tonsils. And then when you get big tonsils, all right, it affects the function. And then when you're mouth breathing, you get a narrow palate. And then when you have a narrow palate, it causes mouth breathing. All right? So form and function are a continuous positive feedback loop. And it's incredible to consider that this idea of the importance of nasal breathing was really brought in the medical literature barely 10 years ago. How crazy is that? It was in 2014 that Dr. Guilleminault put out a controversial statement into the sleep medicine community. In 2014 is the first time that a medical doctor said it's important to breathe through your nose. How insane is that? How crazy is that? He said that the goal of treatment in sleep apnea is continuous nasal breathing. And that was considered controversial when he said it. Who here believes that continuous nasal breathing is the ultimate goal? Show of hands. Amazing. Anyone disagree with that? All right, look at how far we've come along. Look at how far we've come along. Yet these ideas about the importance of nasal breathing aren't that new. George Catlin described this in the book Shut Your Mouth and Save Your Life in 1870. He discussed that nasal breathing is essential for health and longevity, and he described how mouth breathing leads to disease, poor facial development, and premature death. And he contrasted civilized societies where they had a lot of pollution and open mouth breathing to more indigenous societies. And he literally wrote a book called Shut Your Mouth and Save Your Life. Incredible, right? 1870. Also, palate expanders. Palate expanders were described in 1860. Amazing, right? Like 150 years ago, this guy named Angel Emerson described and performed rapid palatal expansion. And in the 1920s, 1912, there was an ENT doctor, 1912, who understood that when you do a palate expander, okay, this patient had a palate expander, and the mouth breathing was overcome. When they do palate expansion, they developed improved nasal space, and the adenoids get better, and they're breathing a lot better, all right? Amazing, amazing. In 1912, ENT doctors understood that a high arch, narrow palate would lead to problems with septal deviations, narrow nasal cavity, and mouth breathing. Is this interesting to you guys? What do you guys think? And then comes along Edward Engel, and he's considered the father of modern orthodontics, okay? And Dr. Engel understood palate expanders, but he really developed many different ways of intervening, not just the palate expanders. And so he set up schools, orthodontic schools, and taught people about orthodontic treatment. Now let's take a pause right here just for 1 second to talk about form and function, all right? Let's take a look at a case study. We have this patient, he's 41 years old. You guys see the tongue tie there, yes? Grade 3, okay? You guys see the scalloping on the tongue? All right, so what do you think is the next step? You need more information, or are you ready to make a decision? Basically, the question is release or expand. Who wants to release? Who wants to expand? Who wants more expand? Who wants more information? What information do you want? You want a CBCT, right? Don't mess around. If you see scalloping like this, don't mess around. Just get the CT. Here's the CT, all right? Now, we have done a study. It involves 200 patients. We looked at different endpoints like intermolar width, scalloping, Friedman tongue position, LPS overflow, and we're about to give you the results. First of all, I'll tell you the Friedman tongue position doesn't do anything for anything, okay? Doesn't matter. You could be class 4, you could be class 1. You think the class 4s are worse, but in the research it just doesn't come out. But we came up with a new finding that was really predictive, all right, of success or failure in terms of assessing for tongue space. And it's really shown here in this CT scan. What we see in the CT scan is the posterior airway space looks okay, but I will tell you up front that this patient is still going to struggle with positional sleep apnea, clenching, and grinding after the release. What's the finding that I'm seeing here? Anyone know? Hyoid, say it louder, or come up to the thing. Hyoid bone. What's wrong with the hyoid bone? It's too low. Do you guys see that on here? This is a dead giveaway that the tongue is going to have a really hard time of getting up in the back. And so you can assess this by looking at someone's cervical mental angle. In this example, you see the hyoid bone is higher. Do you guys see that? So when you look at their chin, it'll be like less than 120, right? Kind of like 90 degrees or like less than 120. In this example, it's almost 180 of the cervical mental angle. Do you guys see that there? Now, the hyoid and the mental tubercle here, the mandible, all right, form a sling that's supposed to hold up the tongue. It's kind of like a hammock, all right? And when the hyoid is too low, the tongue is going to fall. It's not well supported, especially when they're sleeping on the back. When the mandible and hyoid are nice and taut, that's when you can get good function. So now we take another look here, and do you think that releasing the tongue tie is really going to help him with his sleep apnea? No, right? The tongue tie release will help with clenching, muscle tension, and open mouth posture, but it will not cure him of his sleep apnea. So what would we do first in this case, given all that? Let's see a show of hands. Tongue tie, show of hands. Tongue space, it really depends on his goal. That's what it comes down to. If his goal is, I have too much muscle tension, I'm trying to sing, I'm trying to chew, I'm trying to swallow, then yeah, releasing the tongue tie will achieve that goal. But if his goal is to help improve sleep apnea and get him off, oral appliance, it's not going to do that. It's not going to do that. So that's what it takes it for me. If he comes in and says, I want to fix my sleep, I heard tongue tie can help sleep, I'd be like, I don't think so. But if he says, I have too much muscle tension here, I have neck and shoulder, I'm clenching, it's killing me, I don't care what I have to do, I want to be free of this, then okay. So in this case, tongue tie first may help improve tongue mobility, chewing, swallowing, decrease tension, clenching, but it will not help his sleep apnea or tongue-based obstruction. In fact, if he wants to cure his sleep apnea, like cure it, it's probably going to require MMA surgery. And he says, I don't want to do MMA. What do I do? Can I do the tongue tie release? Well, if you understand that it's a tongue space problem and you still want to go ahead, I'm telling you that 90% of the time you'll be okay. Even in this patient, the risk of a poor result is less than 10%. There's less than 10% chance you'll harm him. So if you want to go ahead in that way, it's fine. You do the tongue tie release and then the palate expansion. But it's with them understanding that really what they need is a tongue space intervention, and that the tongue tie can help, but it's really secondary. Let me get some questions, comments. Anyone come up to the microphone here? I want to learn from you guys and your experience. Anyone want to share any thoughts? Please feel free. We learn from the discussion. All right, so we'll set new paradigms and we'll come together. Sure, Alpa, please take the microphone. We're talking about tongue tie versus tongue space and your thoughts on it and the 10% statistic that I quoted. So it doesn't mean you can't do it, just a framework, please.
I basically see adults and I see that hyoid bone hanging low with a forward head posture. So these patients, if they just want a tongue tie release with extremely narrow space, I still don't feel comfortable releasing that even after having a strong myo. And if they don't want to consider palate expansion, then just stabilizing their jaw to just help them be pain-free wherever the pain is, and myo, and that's where we're leaving them at. That's just what we're using in our office.
Thank you for your perspective. I'd love to hear other people's perspectives, how you're managing tongue tying, tongue space, especially for those patients who may not want to do the tongue space first. Anyone else want to chime in? Anyone else want to give their opinion, what they think? It's an open forum, yeah. One in the back right there, please. Dr. Yazdi, is that it? Yeah. That means that if you did a sleep study before and after, most of the time it'll be within error, which means the sleep study won't change. And rarely, like I've had maybe like 20 cases my whole career, sleep apnea gets severely worse. I've had these cases. They've been crippled by the tongue tie release. I've done 5,000 releases, and I'm talking like 10 to 20 patients. It's very small, but for sure they were destabilized. A lot of patients do well, 90%, but there's a few that have been harmed. Has anyone else seen this?
That goes with the territory, right? I mean,
what's that?
It's a standard that it's accepted that with something, that surgery, that there might be a chance of harm. That's something that's
But we're
accepted.
talking about case selection, and I want to get a sense from the audience here whether you guys have seen the same things. Has anyone seen anyone destabilized from a tongue tie release? Oh, go ahead. There's more comments there.
Not specifically tongue tie release, because I'm kind of new to this realm, but we've had patients, adult patients, who come in with like tension in their face and fatigue, and actually Invisalign seems to help with that. Can you touch a little bit on that topic?
Yeah, certainly. So Invisalign is like perhaps one form of getting a better occlusion and maybe expanding the palate. And when you expand the palate, even if it is dentoalveolar, you're improving the tongue space essentially. And when the tongue space is improved, there's more room for the tongue to actually go up and fit in that space.
Hi, Dr. Zaghi. I'm a pediatric dentist. I mostly see children, but I did release my dad. He was 71, very tongue-tied, no tongue space, but very low risk of getting sued by him, so I felt comfortable.
Yeah. How'd it go?
He had great improvements in his sleep,
Yeah.
his speech. He just sounds like 40 years old instead of 70 years old. But I would caution people to, don't get too excited and start doing it on people that could sue you.
I completely agree. Most of the time you're going to help them, but rarely you can harm them. We'll get more comments. We have one here and then we'll Dr. Alpa, yeah. Yes, please. Oh, that's a standard. You absolutely have to do that. That goes without saying. That tongue tone, myofunctional, goes without saying. Is that clear? So this is like advanced. We're going to skip over that because that tongue tone, body work, all that's like a given. It's not even up for debate. We're debating the tongue-tied, tongue space. Yeah.
So I'm a little bit amazed at the fourth component you're introducing with
Okay.
tongue tone and space,
Hypermobility.
because the only other case that I felt didn't work, and I had not done the tongue tie release, I believe another provider had. This patient felt like tongue no longer fits in his mouth and it was slinging back. I do believe this 18-year-old probably had Ehlers-Danlos that
Yeah.
was undiagnosed. So this is just a little aha that just went in.
I'm glad they give it aha. Do you guys appreciate the discussion? I think so, yes? Yes? Yes, let's keep it going, yeah.
I would say I've seen this in infants with really low tone, and it makes me feel, really cautious about suggesting that they have a release when that hyoid is really back, and also when the tongue tone is low, like
Yeah.
that. Yeah, and the hypermobility piece when things are just really, really soft in
Right.
there.
Yeah, so the infants can have a low hyoid for two reasons. One, it could be the tongue tie that causes it, but more often it's a deficient mandible. And so when it's a deficient mandible pushing back, these kids are going to be like airway compromised. And so what it takes is, body work, tummy time, stretching, jaw tension release, red light therapy to release the tension, chewing, swallowing, diet to get that jaw to grow, and waiting for the optimal time. Thank you for your observation. Other people have observations, because research is about observations, right? And so when we come together, we're able to kind of pool our observations together. Please.
We find the same thing. I work with infants. I'm a lactation consultant. And in this realm, we often encounter a lot of babies with very high palates and a tongue tie. And when we do release a tongue tie first, they're still unable to reach the palate to create good suction and be able to, drink well at the breast. So what we do is we try and increase tone and the mobility of the tongue. But then we also take into consideration the mother and her breast shape and her stretchiness of the tissue. And if she has really good stretchy tissue, that may be able to make the compensation to create enough pressure on the palate to begin that natural expansion. We also work with osteopaths and craniopaths that if we're working on the baby between the ages of birth to 3 months, there's a lot more potential to actually move the bones of the palate and expand them with their type of work.
Beautiful. Thank you for sharing these excellent comments. And just to be on the same page, we're talking about the compensation, mid-tongue restriction, posterior tongue tie, rather than anterior to the tip. Would you agree with that statement? Yeah. So if it's tied to the tip, it's a different category, okay? And what we're talking about is this compensated range. Any other questions? Yeah.
Hello, Bibby and Prescott, I read something that they defined what is called the hyoid triangle, which is behind the genial tubercle of C3 to the tip of the hyoid. They made a comment that if the hyoid bone is higher to that, they would be more predisposed to mouth breathing.
So say it again.
It would be
so C3.
C3.
That says right here.
1, 2, 3, and then the tip of the hyoid.
Tip of the hyoid.
And then genial tubercle.
Yeah. So check it out. 1, 2, 3.
And
so
then
this is good here, right? So that's 1, 2, 3 is right here, right?
And the high, and then.
So that one's good. That's good. Okay.
And they
if
say
it's
that,
below 3, hey, super helpful, right?
Mm-hmm. And if it's high, it would be more of a mouth breather. If it's low, because of the flaccidity of the tissue,
so you're
it'd be more of a
comparing the
sleep apnea.
hyoid versus this is 1, 2, 3.
C3, genial tubercle, behind the chin. Behind the chin. Behind the chin.
Behind the chin.
Right there. Yep. There.
Genial tubercle to C3.
C3, and then the tip of the hyoid, the top of the hyoid.
Oh, like this? This is what you're saying?
Yes.
Make a line this way.
Yes.
So this is like really low.
Yes.
Not doing good.
Yep.
And then this is like doing better. Yeah.
A little bit better. Right.
I like it. What do you guys think? C3? Okay. Genial tubercle, hyoid. Hey, discovery. Round of applause for our group here. Way to go. Right? So that's how so I had an observation and. Say it again? Vivian Prescott. Say, you're going to text it to us, but tell me, because I want to give credit.
I'm sorry. Bibby and Prescott.
Prescott. If you can get that over to us, we'd appreciate it. And yeah, okay, awesome. Yeah, and so thank you so much, Dr. Halen, for that. Any other questions or comments on these concepts? Someone learned something new already? Yes? Okay. All right, let's move forward. All right, so I took a little break from that, okay, to bring you back to palate expansion has been around for over 150 years, right? So what happened? What happened? Why aren't we expanding everybody? What happened? Anyone wonder that? Yeah.
We got focused on answering the wrong questions.
Yeah, we got focused on answering the wrong questions, and it was an over-reliance on linear thinking research. So when I was in Switzerland, there was a debate on the crowd, someone said, we need to do a randomized controlled trial to really prove that idea. And I said, I absolutely disagree. Randomized controlled trials can be dangerous because they can misprove a concept. If you overly study something, you do a big sample, and you think you've proved it beyond a shadow of doubt, as was done with orthodontic treatment, you're going to get into an era where you're not only not doing palate expanders, but you're removing premolars. Okay? That's when you're too blinded by the research. It's the research, and then there's a discussion, right? You can't only go by the numbers. It's really dangerous to do it that way. If you're only treating someone based on metrics and how you're measuring the TRMR and how you're measuring space, but you're not seeing the bigger picture, that's where you get into pitfalls. So we talked about Dr. Engel, and then one of the students of Dr. Engel was Dr. Alfred Paul Rogers. And he came to the recognition, based on the people that came before him, that muscle function shapes facial structure. Simple assertion, right? Muscle function shapes facial structure. How exciting. So then he put together these books and these pamphlets showing what exercises to do. And for the first time, we had this myofunctional therapy. This is where it was born, in 1918. These concepts were around from the 1500s with Kachari Mudra practices and Qigong, Chinese medicine taking a look. Ancient Greeks talked about it. Indigenous cultures that we saw earlier in the book, Shut Your Mouth and Save Your Life. Up until the 1920s, where Dr. Rogers started actually implementing these OMT protocols. And so he gave seminars, and he had a student, Dr. Benno Edward Lischer, who picked up this work and gave it a name. And the name he gave it is muscular, functional growth and development. And so that's where the term myofunctional therapy came from. So again, we see that the ENTs were seeing this, and the orthodontists are talking about this. So what happened? There comes along an orthodontist by the name of Charles Dewey. Let's get a boo for this guy. Boo. And he said, we need more research. We should be research-based. We should do cephalometrics, and we should be measurement-based and longevity-based, and we need long-term trials showing stability of our work. And so what he did is he lined up these cases, okay? Lined them up, and he did cephalograms to get everyone's teeth in the perfect occlusion. And the conclusion that he made from that is that no therapy. He was against therapy. Therapy is ridiculous. There's no evidence for it. It's, what are you talking about? You got to get the teeth in the right occlusion. It's point 1 to point 2. You go from here to here. Very linear thinking, not systems thinking. Are you guys feeling me? And he gets credited for coming up with removing premolars. Boo. All right? Well, how about today? What do you guys think today? Where do we stand? Who here is firmly for expansion over extraction? Yes? All right? And isn't it kind of obvious if you think about it? Not to most orthodontists. Yeah, please. How long have you been doing palate extenders, doctor? Yeah. Let's give him the microphone. Yeah, you've been doing it for tell us your history. Yeah. Let's get the microphone, please. Sorry to make you run. Where's our friend? Oh, sorry. he was taking notes. Oh no, turn on.
When I was in orthodontic school, I went 2 weeks to Arizona, Tucson, Arizona, to the Tweed course.
Yeah, this is interesting. This is going to be the microphone, though. Let's get the microphone. You got it?
All right. At the Tweed course, everybody was treated the same.
What year is this, if you don't mind sharing?
Oh, gall. Sometime before some of you guys were born. 1995, something like that.
1995, okay. Tweed
like
course.
that.
It's not that long ago. Okay.
Yeah. Anyway, but no prescription in any of the brackets. The wire was bent to put the tip, torque, in, outs, everything, and every bracket was the same on there. And so we learned how to bend wire to move everything, and everybody was treated with extractions and pulling all those teeth together, and I came out an excellent wire bender.
What did you think? What did you think as you were sitting in that class and learning these principles? What was going on in your head?
At that time, I'm going to be the best wire bender in the world.
Yeah, huh?
Yeah, and I am to this day. I can look at those things and I can bend wire.
And looking back, what are your thoughts looking back?
What a disaster.
Yeah.
Yeah, but it took me getting out of orthodontic school and going into my practice and seeing the difference between, the little kids that he expanded and the cases that I was extracting. I always tell the story of an adult that I took out 4 bicuspids and gave her a perfect bite, and by the time we were done, we had no roots left on the upper incisors because we had retracted them and pulled them back into the bone. And that was a big turning point of me going, I need to figure out something else. And that was when we turned around and said, okay, we've got to grow everybody. So
amazing, amazing. And any other comments about this topic? Anyone else want to give a comment? Yes, Dave?
I'd just like to point out that one of the biggest things that he just said right there is that he recognized that what he was doing was not achieving the goal that he really wanted to do. And he said, I can be critical of myself and say, that's not what I want to do. I want to do something different.
Beautiful, beautiful. It's just observing, reflective, keep learning, keep advancing. Another comment? Yes, please. Good job projecting, Dave. That was good, right? You got that even on the recording.
I think this is a real issue for pediatric dentists. I actually have business partners that were Tweed trained. And so there are times where I actually send them out of my practice to other orthodontists. And so there's kind of a turf war going on between.
So even within your own practice, you have some pediatric dentists or orthodontists?
Orthodontists.
Who are Tweed trained, huh?
Yes.
Wow,
yeah.
wow.
So there is a real turf war between, those that believe in airway.
The Rogers and the Tweed, right?
Yeah. So.
Yeah. All right. Excellent. Well, very good. So what do you guys think in today's day and age? What do you think the mainstream media, what do you think, routine providers think about palate expanders? They're calling palate expanders wrenching apart children's mouths. The bone of children's mouths are being wrenched apart. Ooh, wow. When do you think this was published? Years and years ago? Like last week. This is in the Atlantic. The bones of children's mouths are being wrenched apart. Oh my God. All right? What are you going to do? What are you going to do? So we said 1919, Rogers was talking about myofunctional, come on, get with it. And it fell on deaf ears, so he published first, this is in 1918, but then in 1950, all right, so 30 years later, all right, and he does a reinstatement of the myofunctional concept in orthodontics. So he republished it, and he's like, hey guys, what are you doing with these extractions and all this orthodontic work. We got to focus on the therapy. Get them breathing through their nose, get their tongue up, it'll correct itself. And then he had another student by the name of Daniel Garliner. And so what they were doing actually at this time is Dr. Straub came along and he developed the IAOM so that they can work on this swallowing therapy. And they recruited speech therapists to come and actually work in dental clinics to teach this tongue thrust therapy. And one of these speech therapists was a guy named Daniel Garliner, and he was a visionary speech-language pathologist who worked with these orthodontists on the chewing, swallowing, tongue posture, and he developed the Myofunctional Institute in Florida, and he trained thousands of people. And it's really from his training that we got people like Joy Mueller and Barbara Green and all these original therapists that we learned from. So when you go and you learn from one of the courses here, you can see the history of it. For example, Dave, you were trained by like my own mentor, Sarah Hornsby. Sarah Hornsby learned from Joy Mueller, who learned from Daniel Garliner. All right? So this is your pedigree. How exciting is that? And so we see a growth in the speech-language pathology, the chewing, the swallowing, and it was all focused on expanding the palate. And then a person by the name of Katia Guillameres comes along and says that, hey, when you're doing this, it actually helps improve the breathing. You can take kids with sleep apnea and you can improve their breathing. It's because of this study that Dr. Guilleminault got interested. Hey, there are exercises that you could do to help improve their breathing. This may be the missing link. And so in 2000, and I think it was 13 at the time, 2012, he learned about myofunctional therapy and thought it was critical for the treatment of pediatric sleep disordered breathing. In 2012, I was applying to be the Stanford Sleep Surgery Fellow. So I went there, I met Dr. Guilleminault, I met Dr. Camacho, and there was all this talk about myofunctional therapy, all this talk about nasal breathing, and I met my mentor, Dr. Camacho. I had such a strong interest in research that in 2013, I was accepted 2 years early to be the Stanford Sleep Surgery Fellow, just in my third year out of a 5-year residency. And I spent the next 2 years as like a research fellow with Stanford, doing a bunch of different publications. And one of the publications Dr. Camacho invited me on was this article on myofunctional therapy. And he just wanted me to go through the literature and review it and make sure that everything, we had included everything. And so this article, who here has seen this article, Myofunctional Therapy Meta-Analysis, like a historic landmark that really brought validity to the medical scheme of therapy. And it's interesting to note that there's a lot of different authors here, but one author's missing. Who's missing on this? Dr. Guilleminault himself. Because this study was done by Cleet Kushida in a way to keep tabs on Dr. Guilleminault. Make sure he's not veering too far off. And so it was done in spite of him, yet the individuals who did this had a lot of integrity, and they came out and they published the amazing results that myofunctional therapy is often one of the most effective forms of treating pediatric sleep disorder breathing, helpful in children and adults of all ages with improvements to daytime sleepiness and snoring. This article gets published, I go to my fellowship and I meet Audrey Yoon and Stanley Liu, and we develop an airway team to dedicate more research to these concepts of nasal breathing, tongue, lips, orofacial complex, oral resting posture, good chewing, swallowing. And I went to AOMT courses, and I learned from Bobby Gahary and IAOM, and just learning as much as I could, reading textbooks and articles, learning that, yeah, hey, tongue up, lips closed, healthy breathing through the nose. And when I first started lecturing on these concepts, it was controversial. Other ENTs would call me and be like, what are you talking about? There's no such thing. There's no evidence for any of this. And so, the more conferences you go, you learn from different people. And we developed the Breathe Institute. So I met Sanda at a conference. She gave a business card to Layli. And, I was sold. And she had this vision for what she was trying to do independently for the field of airway. She was a sleep dental consultant at the time, and we shared a mutual vision, and that's how we birthed the Breathe Institute. So from there, we met all of you guys, and we had seminars. Our first seminars were like 3 people, 19 people, 50 people, and it's so amazing to see, hundreds of people who follow our work and really contribute to it with the ideas that you guys provide. And we're so really grateful to all of you. So thank you guys so much for being our supporters and for coming and spending the day to always continue learning with us. In 2019, we published our first publication. This was the first time in an ENT journal that we're talking about tongue tie with myofunctional therapy. And the results were amazing, okay? Patients were very satisfied, yet there were significant complications, okay? Many patients were satisfied, but some were frankly dissatisfied. It was a scissors and sutures technique. 45% of patients had pain, 12% would leave with bleeding. They had 5% numbness of the tongue tip, salivary gland issues, and we were proud of it, but there was something missing. And so as we're teaching this, one of our students, Anna Lichnowsky, who's a physical therapist, myofunctional therapist, said there's no way. There's no way that what you're saying is true. There's no way that myofunctional therapy really, and tongue tie release really helps. So she did a randomized controlled trial looking at exactly that. She compared myofunctional therapy alone to myofunctional therapy with tongue tie release, and she showed in this randomized controlled trial that there are very significant improvements and benefits to the tongue tie release, in a way validating our 2019 article. So this is how we came from an idea to an actualization of the protocol as we know it. However, over the past 5, 6, 7 years, we've been talking about how we can further improve this technique. And so, as you guys have seen, my releases are less invasive, less bleeding, less complications as well. And so now the pain's gone down significantly, down to 3.7% of patients experiencing severe pain. Bleeding is much more rare. Numbness, salivary gland, and revisions needed have also significantly dropped. This is how an observation goes to a case report, a case series, randomized controlled trials, and then again, you start over, observation, case report, case series, cohort trials. Recognize that best practices reflect our knowledge at a given moment in time. And as knowledge evolves, new best practices emerge. And so with our new paper, it's open access. It includes our entire protocol from A to Z. I'm going to walk you through the paper. It talks about everything from primitive reflexes to red light therapy, to serapeptase, to Kenalog, to mid-tongue restriction, to the depth of release. Everything is in this protocol that we've written up, and we feel like it's going to be historical. You're going to look back and you're going to say, well, this is the protocol. And so when you're testing or you're trying to do your own studies, you can refer to this protocol as an established basis upon which you can further grow. Who here has already seen this article? Okay, amazing. We will be going through it. Feel free to download it, share. It's open access, and it has all of our slides and materials that you need. I want to really thank all of my amazing co-authors. I also want to give a big shout out to the International Journal of Orofacial Myology with Nancy Solomon. They give a lot of feedback, maybe like more than you could ever want, but their feedback is really helpful. And if you're looking to submit your publications, I really encourage you guys to take a look at this journal. They're very friendly because it's International Journal of Orofacial Myology. So they're very friendly to these topics, tongue tie, buccal tie, lip ties, whereas other journals are like, this is not relevant to our practice. And they'll help you get it to where it needs to be. All right, so we're 1 hour in. I'm going to show you guys some videos in terms of how to do the release, okay? These will, we'll just show you like 2 or 3 different videos. We'll take a little break after that, and then we'll come back, we'll go through our paper and talk about hypermobility and all the key learning. Sound like a good idea? All right? Any questions or comments? All right, so before I go over the paper, I'm going to just show it to you, okay? and then I'll explain it. Is that okay? Does that work for you guys? All right, so let's just take a look at our release technique. Hi, Katie, welcome. It's great to be here with you. You did your palate expansion.
I did.
And now you're ready for the tongue tie.
I'm ready.
Let's take a look. Go ahead and lift up your tongue for us. And just lift the tip of the tongue up. Just the tip of the tongue up to the front two teeth. We consider this a mid-tongue restriction. You can see that there's restriction due to the lingual frenulum here. It's actually restricting the mid-body of the tongue. This can contribute to clenching, grinding, neck and shoulder tension. And now we're going to go ahead and release. Can you put some topical anesthetic? Open up your mouth for me. Lift up. Lift up your tongue. Excellent. And this is marking with it. We're using a hemostat, okay, to outline the incision. There's a small blood vessel that runs up and down the middle. You can see a little blood vessel. Take that in turn for me. I'm going through the blood vessel through and through. Stopping prematurely will cause you to bleed. Give me a little hemostasis. We're going to dry up the top edge of this blood vessel here. Again, note I'm doing the butterfly hold maneuver. So I'm pinching the lingual vein so it doesn't bleed while I do it. You can see the muscle protrudes out a little bit here, the little muscle belly. So I'm going to even it out here. Close. How are you?
Okay at all.
Great, love it. Open. Suction hold just like you are, okay? Drop your tongue. Let's stick out your tongue. This looks really good, Emily. Before we finish, we're going to give a little bit more marking. Great job with your therapy, huh? Close. So you can see that you have lingual vein right here. Right here, where the mucosa. You can see I'm pulling it outwards so I don't accidentally get the vein or the nerve. Tip of the tongue up. Good. No periapical bone. So good. Close and swallow.
Wow, that was amazing. I can't believe how fast it was too. Yeah.
Efficient, targeted, safe.
Yeah.
Thanks for
Thank you so
trusting us. You got it. My
much.
pleasure. My pleasure. All right. So this video shows you the overall procedure. Okay. Any questions or comments about that so far on this video? Okay, you guys can see it's a little bit less involved as compared to prior. The major question you guys have, I'll say it for you, right, is how do you know when you're done, right? Anyone have that question? Okay, should I beat you to it? Anyone want to ask it? Somebody ask it for me, go ahead. How do you know when you're done? Okay, exactly, right? So like how far, what's that endpoint? What's that endpoint? Let's take a look at this video to help us kind of hone in and like kind of tease in on what we're doing. Here's a patient, she's got a grade 4 tongue tie, it's quite severe. You can see that she has some tongue overflow, she has some tongue space issues. Her goals are mouth breathing, clenching, bruxism, tension. She has the poor sleep, her palate's not the best. You can see she lacks the incisor show, so her maxilla is deficient. Nevertheless, we know that if you're grade 4, you got clenching, bruxism, muscle tension, the release is gonna help. So where do you draw that line? And how do you do these procedures? When you have a grade 4, the first step is to convert the grade 4 into a grade 3. So that's the first step. Just to release until you're at a grade 3. Okay? You release a little bit until you get the little tip up. Now let's look at how I'm deciding to do this. With the grade 4s especially, they don't have a lot of muscle control, so I'm doing the pushback technique here. Yeah. Good. Every tongue. Excellent. Then screening setting. Open. Excellent. You're doing so good. Okay, so we do the floor of mouth hold. Lift up your tongue. Still tethered, okay? So that's the first step. Floor of mouth hold. See if it gets up. Still restricted. Floor of mouth hold, lift up your tongue, up to the front two teeth. Okay, much better, okay? Stick out your tongue for me, stick out your tongue, point it all the way out, good. Good, good, good. Good. Drop your tongue. Good. Close your mouth. Open. Lift up your tongue, up to the front 2 teeth. Good. Really good. Okay. So I'm really happy with that. Open up your mouth. Yeah. Good. Let me tell you why this is the endpoint with the refined endpoints technique. Lift up your tongue. So good. Up to the front 2 teeth. A little bit of weakness and things like that, but no dimple. Okay. Stick out your tongue for me. Okay. So you can see the muscle is deep to the fascia there. Okay. And generally the mobility, everything looks really good. So there's nothing sticking out here. Okay. So those are like the 2 main aim points that I look at. Open up your mouth all the way. Lift up your tongue. Yeah, it looks really good. Suction up your tongue. Good. Excellent. Good. Close. Suction hold. Open. Take the tip of the tongue backwards. Close and swallow. Open. Stick your tongue out of your mouth. Looking good. Okay, so I put the sutures a few, 4 to 6 millimeters apart here. Tip of the tongue up. Open big. Tip of the tongue up. Pick it up. Good. Stick your tongue out. Good. Tip of the tongue up. Stick your tongue out. Good. So it's your sutures now, okay? See. Good. Prepare your alcohol for the rest. Close. Open. Good. Lift your tongue up. Okay. Dry it up. Okay. Good. So just maybe 3 sutures here. Tip of the tongue up. There's the result, okay? Excellent. We're now going to do some red light therapy for you, okay? Yeah, very good. So here we're showing you the endpoints of the release with the floor of mouth hold maneuver. You don't want the genioglossus protruding outwards, as I'll show you. I have another case to show you after the break. Not feeling for tension. We believe that the functional endpoints really do matter, and it helps a lot. So we'll take about 5 minutes of discussion. We'll take a 15-minute break and then come back at 10:30. Let's have some discussion. What do you guys think about the endpoints? Who here has tried this more refined technique? What are your thoughts? Yes, comment here. It's cleaner, right?
Cleaner, simpler.
Cleaner, simpler, get in, get out, less complications.
Yeah, and they heal up quick.
They heal up quick, good. Anyone else? Yeah, comment in the back there.
I just had a question about the technique with the suturing. Is that essential? Because you were doing quite a bit of the suturing for that procedure.
Great
What
question.
if you just left it open?
A great question. So if you leave the wound open, you get a bigger wound. And we know that the bigger the wound, the bigger the scar. So what's going to fill that tissue is actually scar tissue. And based on our experience, you do get superior results the smaller your wound and the more closed that it is. So yes, sutures are an integral part. When sutures cannot be applied, periacral glue used to achieve primary intention healing with fewer sutures is also a really good approach. If you suture too much or too tightly, of course, it's going to harm things. But nicely placed sutures to approximate the wound will give you a smaller scar, and the smaller scar means more functional, healthy tissue.
What kind of sutures?
I use 4-ochromic suture. Some people use 5-ochromic. Some people use other materials as well. Yes? Yeah, I put periacral glue between the sutures, and the periacral glue is like really helpful, especially if you get into bleeding. I feel like it's safer than something like silver nitrate, for example. Silver nitrate can cause a lot of nerve injury and bleeding worsen things, but you put a drop of the periacral. Yeah. Yes, there is fascia remaining, and I'm glad you brought that up, okay? There's superficial fascia and there's deep fascia. And when we come back after the break, we're going to talk about hypermobility.
Okay.
And we're going to learn that the superficial fascia is intended for glide and movement, and the deep fascia is meant for stability.
Huh.
It's supposed to be load-bearing. And so what we're learning is that it's the superficial fascia that you want to get through, and you want to preserve the deep fascia to the extent possible, unless you have to go through the muscle, which even in those cases, you really want to preserve as much of the deep fascia as you can.
Oh, interesting.
Which is a key point. So it's actually called fascia-preserving technique.
And that's in infants too?
The principles of mid-tongue restriction and release and all that also apply to infants. So the smaller the wound, the better the results. Meanwhile, it's harder to execute such a high level of precision in infants. So in infants, the other considerate is access to care, getting it done, getting in and out in a safe way.
Got it.
So no, I don't suture babies unless it's like a second or third revision or if it's under anesthesia. It's hard to suture babies, but yeah, you want to keep it small, you want to keep it clean. When you do go into the muscle, you do get a big wound if that's necessary. You oftentimes will need serapeptase catalog revision procedure the deeper you go and the more you violate the deep fascia.
But might be less refined between the deep and the superficial fascia in infants is what
What's that? You'll be more refined if you can avoid the deep fascia.
It might be harder to find that definition.
You'll have less complications and better results to the extent that you can be fascia and mucosa preserving, but also getting your endpoints.
Great. Thank you.
Yes, Dr. Harlem. Yeah, I like that. Yeah, so the no palpable tension, he calls it the Murphy maneuver. If you have a reference, we'd love that. But basically, kind of feeling along there for any palpable tension can be helpful. Yes, Soroush. So the question is with Eiffel Towers, and so and then what am I doing? So Eiffel Towers, I never go onto on this side of it, on the attached gingiva. I always release above it, and it drops down. When you release below it, the whole sublingual caruncle will come up, and you're really out of bounds. Yeah, but I'm finding it resolves nicely. Back there and back here.
When you see the muscle protruding, but you're also seeing the vein and the nerve, do you stop and you tell the patient that the results are going to be compromised?
No, so so the genioglossus muscle is never released beyond the vein and nerve. So hopefully, instead of releasing the genioglossus from so high, you want to release it closer to the sublingual caruncle and just release it enough so that it can pop out. This is a good demonstration. There's two ways of doing the release. You can come straight through here and cut all the way through. You'll have to cut through a lot of muscle, all right? And then you'll get into nerve and vein territory and you'll feel very uncomfortable. Rather, you just want to clip it kind of low and just enough so that the fascia releases the muscle. So drop where you're releasing it. You're going too high. Go lower and just kind of carve it out from the floor of the mouth. Okay, and I'll show you another case. Yeah. Question there, and then we'll go to Dr. Alpa just because of the microphone distance.
As a myofunctional therapist, we do the forklift and the floor of the mouth stretch, but Dr. Richard Baxter was saying doing like the push and down and lift. Would you do the same with the sutures?
We have our protocol, and we like our protocol. We've written it out entirely from A to Z, as I'll demonstrate to you guys. I think it could be really helpful for you guys if you're interested in seeing the protocol to come to our Myo workshop or to talk to one of our therapists. It's different than traditional therapy. So, but I do like the forklift, and I like lifting better. And even for babies, yeah, I like the lift. And I also really like sleeping tongue posture hold and just being less traumatic. But a little light scoop, I'm all for it. Dr. Baxter knows what he's doing. We have very different populations. We don't like reopen the wound like that aggressively. We don't do that in our clinic. I live in like Los Angeles, like Beverly Hills. Like he lives in like Alabama. He's trying to. It's like he's different populations. Okay, so we're like red light therapy and body work and like organic and homeopathic. Okay, he doesn't do homeopathic, right? So it's different populations we're talking about. Yeah, question? Yes. Yeah, just use a little bit. Whatever you're thinking, use less. You guys agree with me? Very little. If you use too much, it gets clumpy, it gets gross. Dr. Alpa has been waiting patiently here. The microphone's close to you.
No, I was just going to mention that the technique I learned from you about pushback to identify on patients that have a severe tie that you're not sure if you're going to do in 2 stages. After the endpoint, I think I've learned that from you, just checking not just a finger hold, but just push back again. And if you don't feel that restriction, then
Absolutely.
We stop.
Yeah, so doing the pushback and feeling for the tension can be really helpful. Any other questions? Yeah, so I also want to give a shout out to our Myofunctional team and our Myo Masterminds cohorts, okay? So what these ladies do is we have ideas, we implement them, and then they go and they teach their Myo Mastermind, the Myofunctional therapy cohorts, and over the course of a year, our protocols get refined year after year after year. So with that, go ahead and enjoy a 15-minute break. We'll come back around 10:30, or maybe a 12-minute break if that works for you guys, and we'll continue on from there. All right. Thank you guys all so much for coming back, all the participation. In the second half, we're going to do like a brief overview of the protocol and of the paper. I'll show you one more procedure, and then we'll talk about hypermobility. Sound like a plan? Good? All right. So I really would love for you guys to get familiar with this paper. It's called Lingual Frenuloplasty with Myofunctional Therapy. And we put a lot of work into this paper. We basically put all of our research in the last 5 years into one paper. Instead of publishing a lot of different little papers, we just all clumped it together so that it could be there for you guys as a resource and a protocol. Really proud of the introduction section. The introduction section defines lingual frenuloplasty. It's important to define it because the existing literature calls lingual frenuloplasty like a Z-plasty or something obscure. It also misdefines what tongue tie is. So this paper in the first few sentences has the definition of lingual frenuloplasty, of ankyloglossia, what the definition is a condition of limited tongue mobility. It establishes the definition of myofunctional therapy and everything that can go wrong in terms of compensations. It talks about the role of tongue tie on speech and feeding, primitive reflexes, and so we're really proud of just even the introduction alone really sets the frame for what we're doing. Second, it has the materials and methods, and this exhaustively goes through and writes out exactly what our protocol is. There's like nothing left to the imagination. We used the Ferris 6. We did the tongue range of motion ratio. We looked at the floor of mouth hold maneuver. So this paper is literally describing what is the floor of mouth hold maneuver. It's talking about the concept of mid-tongue restriction as opposed to posterior tongue tie. And so we, for the first time, have a validated paper that is talking about all these things. Here's our surgical protocol, all in depth. What I'm most proud about is the clinical protocol that comes as part of it. When you download the paper, at the bottom, there's supplementary information, and it will give you this clinical protocol visual companion guide. The visual companion guide gives you all of our, the good stuff we have that we all lecture on, including our entire orofacial myofunctional therapy protocol. And we've written it out week by week, day by day, what to do, what the goals are, in a very high-level academic way. so that we could describe it in a very standardized fashion. Our protocol differs significantly from the traditional way that AOMT and IOM have been teaching it. What we have come to understand is the important role of compensations, which means using the neck and shoulder muscles to lift up the tongue. And so, it's not just about forcing the tongue up, but about achieving a resting posture, and we're really proud to be framing the therapy in this way. For our results, okay, we showed our demographic considerations. A lot of patients had oral dysfunction, open mouth posture, neck and shoulder tension, bruxism, headaches, TMJ, and speech issues. We have our TRMR tip and LPS scales, but we also are writing out now the normative ranges for what the tongue should be able to lift. And note that we're no longer calling it posterior tongue mobility, but rather mid-tongue mobility. And so whereas you maybe have seen this paper before, it's important that there's a clarification here that this used to be called posterior tongue mobility, but we're now calling it mid-tongue mobility. So if you want these figures, it's in the visual companion, it's published. What we're doing in practice is not so much measuring the TRMR except for research, rather we're using the bite blocks or just eyeballing it to get into 3 categories of normal range, compensated, or restricted. And we talk about how to assess with the bite block more in depth in our courses. If there's one thing people should leave here knowing, it's understanding how to do the floor of mouth hold maneuver. Here we have a little QR code that takes you to the video of us demonstrating the floor of mouth hold maneuver. Who here is familiar with it already? Who here is new to it? Who's never seen it? Okay, so new to it. Really encourage you to take a look, but I'll play the video here for you. But this video is also published within that paper.
Okay, and so stick out your tongue for us. And lift up your tongue. Okay, lift up the tongue to the front 2 teeth. Okay, so you can see that it looks like a grade 2 tongue mobility, but really she's bringing up her entire floor of the mouth. And if we hold her floor of mouth down, where it should be, and ask her to lift up, you can see she can't get it up. She just cannot get up her tongue, and you see the dimple right here that reflects the side of the frenulum attachment point.
All right, so this is called the depression on the dorsal surface of the tongue, the floor of mouth hold maneuver. In our practice, we had 6% of patients with grade 4 tongue tie, 34% with grade 3, but the vast majority were these, mid-tongue mobility restrictions as characterized most effectively by the floor of mouth hold maneuver. So it's really the floor of mouth hold maneuver was like 95% sensitive for identifying the mid-tongue restriction. And it's not 100% because some of the grade 4s don't change with the floor of mouth hold maneuver. So that's how we feel that, it's
so let's take a look. Open up your mouth for me. Good. Lift up your tongue. All right. And let your tongue go down. And stick out your tongue. Very, very, very good. Lift up your tongue one more time for me. Good. Rest your tongue. Good. Lift up your tongue. Fantastic. And stick out your tongue one more time. Excellent. Excellent. So good.
All right. I'll take any questions or comments on our assessment, high-level questions, if there are any. On assessment, mid-tongue restriction, any comments? You guys good with it? I don't want to spend too much time on assessing tongue tie because I think it's like more of an introductory concept. You guys good with it? All right. So everything's kind of put there. We also have this tongue anatomy. Have you guys seen this figure before? You guys love it? Yeah? It's now published. If you want it, it's in the article. Big thanks to Chad for putting this together. Talking about tongue blade, tongue body, the middle of the tongue, the sounds that are produced, and all that. We have our laser settings published, and yes, using the laser significantly helps diminish pain, bleeding, and you get much better depth of dissection. All right, here's an important key takeaway point. All right, so the tongue ties that you guys have seen are either mucosal and fascia, or sometimes they also include the genioglossus muscle. And in this study, what we learned is that you get increased swelling and complications the deeper that you go. All right, let me show you. In my office, nobody comes with a mucosal only. You're not flying to Los Angeles waiting 2 months for a mucosal only tongue tie, okay? Those get treated elsewhere. The ones that come to me are more advanced. Among the ones I'm seeing, about half of them, 47%, were mucosa and fascia only. 52% of the time I got into the muscle. Would you guys say that in your practice is about the same, 50-50? Or do you think it's more or less what you're seeing in terms of involvement of the muscle? Less? Less? Okay. So, about 50-50 involvement of the muscle, and we're talking just a little bit of muscle, but we find that when you stay out of the muscle tissue, when you stay out of it, just in the superficial fascia layer, you barely get any swelling, 94%, maybe a little moderate sweating, like very unusual, okay? But if you do get into the muscle, you can sometimes get very severe swelling. It's actually a 4-fold risk, if there's muscle tissue involved. Does that make sense to you guys? The deeper you go, the more risk of complications. All right. So here we see the satisfaction rates breaking down by age cohorts and the complications. So while we maintained high satisfaction rates in the 86% range, we see that there's much fewer patients that are dissatisfied and a lot more neutral compared to the prior paper. So the prior paper, people were ecstatic, like super happy, and there were some that were very dissatisfied. So it was the two poles. Now what we're seeing, people are still satisfied. Many are a little bit like neutral, which means that, they're maybe expecting a lot from it, so expectations have changed, but we have far fewer dissatisfied patients. And it's the dissatisfied patients that are having complications, issues that you have to deal with. Pain has dropped significantly. The severe pain has dropped. Bleeding rates have dropped. The severity of bleeding has dropped. Less numbness, less salivary gland injury. And also, we're doing very few revisions these days as compared to before. Any questions about those results? Any comments? Okay. In terms of wound healing, we understand the phases of wound healing, and we've kind of published this out there, what to do at each phase, and the care instructions, early on, in the middle, what kind of stretches to do, what to monitor for, how to manage it. And we've also published here the WHIM Scale. So the WHIM Scale we're really proud of, and we've lectured on this. Everyone's familiar with WHIM Scale, yes? Anyone not familiar with it? Okay, a few people. So the WHIM Scale is an objective tool to assess your outcomes at the 2-month mark and beyond. So what you're doing is you're taking a look at the wound and saying, how thick is it? All right, what's the color discrepancy? How's the wound texture? How's the wound tightness? And how's the mobility? And giving it a score from 0 to 10. 10 being perfect healing. So if it's small, the color's good, the wound texture is good, the mobility is good, 10 out of 10, excellent. If it's not so good, so if you wanted to do a study, sutures versus no sutures, then you would probably see higher WHIM scores at 2 months for the ones with suture versus no. I haven't done that study, but if you're interested in exploring that in your own practice, that's how you would assess it. So it's a really good, useful tool. If you want to see how does serapeptase work, how does Kenalog work, how does red light work, I'll tell you anecdotally, I do find that the serapeptase really helps and red light therapy really helps. So I have some patients that I'm seeing at 2 months, 10 out of 10, wow. And I asked them, hey, you have a 10 out of 10 score, what did you do? And they came up with a specific serapeptase protocol of applying it once daily for week 2 and once daily for week 4. And so that's my current serapeptase protocol as opposed to, other more complicated regimens. The red light therapy, those who get a home red light therapy and apply it are really getting good results, but these should be studied in more detail. And we'd love for you guys to start implementing this and coming back next year with your results. Hey, we did a bunch of patients, we didn't use serapeptase, here are the results, we used it, here are the results for WHIMs, or we did red light therapy before and after, or other interesting things that you have. Who here finds this to be a helpful tool? Yeah? Good? Question. Yeah, so the way the WHIMS scale works is a 5-point scale. It's assessed by the therapist or the doctor. And the first scale that you're looking at is how thick is the wound, right? Look, this is 1 to 3 millimeters. This is 3 to 5. This is more than 5, or it's open. So 1 to 3 gets 2 points. 3 to 5 gets 1 point. That looks disgusting. You get 0 points, okay? This one, color. The color looks fantastic, 2 points. The color looks like it's coming. Usually at the 2-month mark, it's integrating. It's almost there. This, scar, okay? It looks white. It's distinct. 0 points. Is it smooth? Is it raised? Is it rough? Is it flexible and good? Is it a little bit of tension? Is there a lot of tension? Is it good mobility, compensated mobility, or restricted mobility? So these are the different dimensions that we have to objectively assess how the wound is healing. Yeah, Layli, yeah.
I just wanted to add, I know Dr. Baxter mentioned this in his keynote, but if you guys want to see Dr. Zaghi applying this with Dr. Baxter's, the scar tissue and his re-release, that's on our YouTube too, so it'll be a helpful little tutorial walking you through this.
Other questions? Yes. The youngest, Jennifer Tao describes it on infants. However, there's pros and cons to using it on infants. You can get complications. We've had people aspirate it, so I'll show you the best techniques. And that means like they swallow it and then they're like choking, coughing. But even if you aspirate it, it's still okay because it's supposed to break down. It's a silkworm enzyme, so it breaks down fibrin. So we've had a few cases where like a grandparent or something tried to spill it in there and the kid aspirated on it. So yes, you can use it on infants. We have a best practice in terms of how to do it. I'll show it to you now since you brought it up. But basically, you want to put it on a little gauze and then make it a little wet and then gently put it there. You don't want to aerosolize it and put it inside.
Perfect.
Okay, but we'll talk about the best practice for serapeptase when we get there in a few slides, okay? All right. Any other comments on the WHIM scale? You guys like it? Any room for improvement? You guys like it? You guys going to start implementing it? Okay, so when you guys, next year when you come and you put your results out there, show it at 2 months, show it at 6 months, okay? Like it was a restricted tongue mobility. We got it to, WHIM score of 10 out of 10 and the patient sleep apnea improved or whatever, or their symptoms improved. Or you could say didn't improve, but the WHIM score was like a 2, right? So it's not just about doing the release. How does it heal? If it doesn't heal well, why would you expect the speech to change? Does that make sense? Comment there? Okay, yeah. All right, so patients were satisfied. There were some who were dissatisfied. And the ones that were dissatisfied, like almost always, it came down to a tongue space issue. So we do screen our patients with a FARA 6. If they have big tonsils or they're mouth breathers, they cannot realistically do myofunctional therapy if you have huge tonsils and adenoids and you can't nasal breathe. Nasal breathing is number one. So we screen for that. Like for example, let's say you have a tongue tie, but you also have big tonsils, adenoids, narrow palate. You release the tongue tie. Is the speech going to improve? What do you guys think? No, it's not going to improve. They still can't breathe, okay? So don't include those patients in a study if you're looking at the effect of tongue tie release and myofunctional therapy on speech. Really focus in on patients who can breathe and who can fit this protocol. The second thing is that for adult patients, very important to assess for tongue space, tongue scalloping, tongue overflow, Friedman tongue position palatal flutter. Just in the next year, Friedman tongue positions coming out, okay? And hyoid position, cervical mental ankles going in, all right? So you guys heard it here first. You guys agree with that? What do you guys think? Should we make history and codify that? Let's see who here agrees. All right. So we're going to codify that. All right. So next year's FARA 6 plus 4, Friedman tongue positions out, and then some iteration of a hyoid position is going to be put here. And we're probably going to use the maneuver that Dr. Halem suggested, Layli, like relative to C3. No, this one would be, sorry, this is just not CT. This is just cervical mental angle, acute obtuse or neutral. Okay. So is it like less than 120? Or is it like 180, all right? It'll be a yes, no. What's that? It doesn't matter. We've tried it. I've tried it on 2 studies now. It could be a 4, you could be a 1. It doesn't predict anything. You think it would, but there's no study that actually shows that it does anything other than predict ease of intubation. I really tried to try to find a relationship, like looking at the forwards, looking at this. It doesn't play out. Yeah. Do you feel differently? Do you feel like it's important to look at? Miss, yeah. Do you like the Friedman? That's elongated soft palate, and the Friedman does not apply to that. So the Friedman does not get better or worse if you laser the soft palate. You look for it on a CT, and if the soft palate is at the occlusal surface, you're fine. If it's way below the occlusal surface, then you have an elongated soft palate. But the Friedman is mouth breathing. If you're a mouth breather, it goes up. If you're nose breathing, it goes down. And you don't want to take it up so high that you're seeing the uvula up to Heidi here. So I wouldn't use the Malampati for like elongated soft palate. I prefer looking at the position on a CT scan, for example, or if it's like, you know, you're really trying to see back there, it's really a 4, it's really elongated, but it doesn't play out. Yeah, if you guys find that it plays out, please send me that. I'm really interested. I really want to use it. Like I really want it to fit. It's just not fitting. Anyone else feel strongly the Friedman tongue position is like a really wonderful thing that we should for sure keep? It's okay. I want to keep it. I really do, but it's just not fitting. Are you guys okay if I let it go? You guys okay? All right. All right. We're going to let it go, okay? All right. So when you do a CBCT and you want to look for airway, it has to be with closed mouth, okay? If the mouth is open, it's not, the posterior airway space changes with mouth open, mouth closed. Mouth has to be closed, teeth have to be together. If the teeth are apart, the airway changes. You know that. You increase the vertical, the airway gets bigger, okay? So, you know, your mouth is open, you don't know. If the tongue is like, you have a bite registration in there, it's not representative. If you're reaching for the chin rest, you're increasing the nasion-basion C3 angle, and you know, this is going to open the airway, this is going to close the airway. We've shown that in our research. Any questions or comments about CT protocol? Anyone looking at the nasion-basion C3 angle? So the average measurement is about 105 plus or minus 5. If you're less, though, it doesn't really mean anything. If you're like the 90s, sometimes they're too straight for weird reasons, so it doesn't mean anything. But if you're like 120, that's a problem. Okay, that means you have way too much forward head posture. And I really use the nasion-basion C3 angle, especially when I'm looking at the posterior airway space. So here we have a patient. She wants to have her tongue tie released, okay? All right, so I'm not too excited. You guys see the tongue overflow. You guys see all that, yes? I do a CT. She's 33 millimeters, so it's borderline. It's not less than 32. So then I look at her posterior airway space. Her posterior airway space here is showing like 3 millimeters or something like that, 3-4 millimeters. I put it on the slide here. What is it? Like 4 millimeters of posterior airway space, okay? But the nasion-basion C3 is 118. How do I interpret this? All right? This means that with her head open, she's only 4 millimeters. And the most you can comfortably get is like 120. The highest I've ever seen is like 123, 125. Okay? So that means that if you have a little bit of swelling, you have to go even more forward. Otherwise, you're going to choke, and you're going to choke on your tongue, and it's not going to be good. So this is a patient based on, you know, perhaps the hyoid position and the nasion-basion C3. We consider those things. This posterior airway space is a little bit scary. Do you guys see that on here? Do you guys agree? Okay. We're taking a look at this case. Another person who wants to get it done, narrow palate, okay, 29 millimeters. We said more than 32. It's not even really a tongue tie. Like, maybe it's a tongue tie, okay? If you really want to do this, stay mucosal and fascial only. Don't promise them too much. You know, and then look, 128 forward head posture. You guys see that there? 128 to get that airway that she has. So again, the teaching point here is not only the posterior airway space, it's the posterior airway space in the context of the head neck angle. Is that a clear teaching point? All right, so this case comes along, and also there's a little bit of tension here, okay? It's a little tongue tie there. Inner molars, 33. The posterior airway space is like 0, right? Wow, 0 airway space. No, her neck is tucked in. Do you see the nasion-basion is 101? If she was like 105 or 110, her airway would open up. Therefore, yeah, she's narrow, but in the context of her head neck angle, she has room for compensation. Anyone who does a CT scan like this is going to have a small airway. So this one, I go for it, I release her, but she's still narrow, okay? And narrow patients have more complicated healing, the sutures fall out early, and you don't get the best healing. So even if they're okay from a tongue space perspective, it's still not ideal because the tongue is squeezed in there, and there's something with the squeezing or something with the tissue that you get more scar tissue, all right? Questions, comments, tongue tie, tongue space assessment, what do you guys think? Let's have a little discussion. Do you guys like these kind of things, like less than 32 millimeters increased risk? look at the posterior airway space in the context of the Nasion-Bayesian C3, make a judgment call. If you want to do it for the indication of neck and shoulder tension. Don't do it for sleep apnea indications per se. Anything else? Yeah.
Yesterday on a panel, someone asked a question about the sutures not staying in beyond a certain amount of time. So do you feel that patients that have a narrow space, those patients, in your experience, do you find the sutures fall out earlier than the ones that don't?
I'd have to ask my Myo team. What do you guys think? I don't know if it's a one-to-one. If the narrow palate, the sutures fall out. I don't think they fall out sooner, but the healing is oftentimes, they're probably going to need Kenalog. If you have a narrow palate, I tell you, you're coming in at 2 months for Kenalog. Like, probably going to need Kenalog.
Okay,
you're not going to be a 10 out of 10 on the WHIMs. You're going to be like a 7, 6.
So there's really no correlation to who would have a better success with the suture staying beyond 3 days.
If you have hypermobility issues, the sutures can fall out early.
Okay.
Because the collagen's not as good, and if you're aggressively stretching or other things like that.
Okay.
Yeah, but also limited tongue space, just I'm seeing like worse healing. Other questions? All right. Good, yes, Dr. Yazdi.
Dr. Zaghi, can you differentiate between low tone and hypermobility? Can you just, seems a little confusing.
Oh, for sure, yeah. So tone refers to the muscle, right? And hypermobility refers to like the fascia that envelopes the muscle. So if you see the tongue like quivering, that's like a tone muscle strength issue. But if the whole neck, everything is just limp, like there's nothing like holding it together, then that's more of a fascia mobility issue. But we're getting there now, and I'm going to hurry this part up along, okay? Tongue tie is a multifactorial problem. Therapy does better. We're doing red light therapy. We're doing this immediately afterwards for a lot of our patients, and we're doing it to the tongue. We're seeing improvements. Do you guys want to see another procedure, or do you want to jump to the hypermobility stuff? Hypermobility stuff, okay. So I had another procedure here, but we'll just kind of move it along. We talked about the endpoints, wound closure, periacral glue, okay, just a little bit. Serapeptase, I talked to you guys about, using less is more, all right? The floor of mouth hold maneuver, all right. So what's next, all right? So what's next is, tongue tie, tongue tone, tongue tie, tongue space, and hypermobility, all right? And so why are we talking about hypermobility in the context of airway? Why are you even talking about it? What does that have to do with anything? Like, anyone have that question? Anyone want to answer? Ask it for me? Go, Dr. Alpa. Why are we even talking about it? You guys have that question? Where does this come from? You have that question a little bit. Like, what am I even talking about, right? All right. It applies directly to this. And let me explain to you why. You guys want to release the tongue tie to release tension, right? Is that why we're doing it? To release, who here has seen patients benefit? You release the tongue tie, they have less tension. Yeah? They're clenching less, the tongue goes up, less tension. Oh, wonderful. Less tension. Yes, there's less tension. You're releasing the fascia. You are releasing the fascia. Amazing. There's fascia from head to toe. Okay? We had Tom Myers show us this dissection. From toe to head, there's fascia. Okay? And in tongue tie, the fascia is too tight. It's too tight. It's holding everything forward. So the head is forward, the neck is forward, and you release them, and the tongue pops up. Everyone's seen this, yes? Everyone believes this. Do I have to show you testimonials? You believe it, right? You believe it. But not everyone's fascia is the same. There are some people who don't have tight fascia. In fact, their fascia is too loose. It's too loose. So here you are saying, I'm going to release your tongue tie, release your fascia, and that's actually not what they need, right? Their fascia is not too tight, it's too loose. So hypermobility refers to joints and connective tissues that move beyond typical ranges. You guys with me? Let's take a look.
Now you're going to meet a record breaker who's truly unbelievable. Before the break, I'll ask you which one of these three guys could do unreal things with his skin. So, which one of you guys is it? Oh my God, I would say it's you. Would you say it's this guy? Come through here, Gary. Gary, turn, everybody. Nice one, Gal. That's unbelievable, Gal. Can you do anything else?
Yep.
Well, can you show us?
I'll set my top off in.
Gary, take it easy, Gal. We only want to see arms and necks here. Pretty nice. Show me a little something. Let me feel. Your neck up. Can I pull it? Go on, off you go. Oh, God. When did you find out you could do that, Gal?
I was probably about 8 years old, messing around at school, and I asked a friend next to me, "Can you do this?" I replied no, and that's when I realised I had something special.
Is there a reason you can do that? What's the reason behind it?
I have a very rare skin condition.
Does it hurt?
No, not at all.
Okay. Well, I know the audience are gagging to see some more. Can you show us what you can do?
Yep, no problem.
Brilliant, brilliant. Okay, check this out. Oh my, turn around, Gal, let them see you behind as well, just. Have you ever seen anything? More, Gary, give me some more. Did you, but. Now that is what. Go on then. That is what I call a tie around your belly. What about your legs, everything?
Use a member of the audience.
Yes, please. Yeah, use anyone. Use a lady in the red. Go on.
Give me a finger. Give me a finger. Right. There you go.
Oh, enough, Gary. Gary, come here. Oh.
Have we seen
Can
enough?
you
Can I play it?
Can you tell you now you're going to meet a record break?
I think we saw enough,
It's
right?
truly unbelievable.
All right, so you guys get the picture here, okay? So then he shows his joints and all that, okay?
Okay, a little bit more.
That is, okay. This is called skin hyperextensibility. You're never going to forget it, right? Okay. This is skin hyperextensibility. So why is the skin so hyperextensible? What's in the skin that keeps it kind of contracted and tight? What is it? It's collagen. All right? So there's collagen in the skin, type 3 for load bearing and type 1 for elasticity, that is in the skin. And if you have a condition in which the collagen just isn't right, well, it's not tight. It's not a tight rope. It's like a loose rope. And it's too elastic. You guys feel me? You guys with me? Guess where else you have collagen? In the fascia. The fascia is called extracellular matrix. And there is a lot of good stuff in there. There's collagen, elastin, proteoglycans. There are cells in there, nerve cells, mast cells. Okay? Mast cells are predominant in the superficial fascia. And you have fibroblasts that are making all of this interstitial matrix, keeping the tissues together. So in the skin, you have 60 to 75% of it collagen by dry weight. In the superficial fascia, you have 30 to 50%. And in the deep fascia, 85% of it is collagen. So far, so good? All right. This is how collagen is made. It's made from fibrils. So your cells have DNA. It makes a protein. The protein wraps around itself. And then 3 fibrils come together to make a really sturdy, nice triple helix. Anyone like braiding hair? You guys braid hair? Okay. So you want the braid to be like nice and clean and not frayed, right? And then you got a nice like little braid in the back of your hair, right? Well, what if it's like all the hair is like all over the place, all right? It's not going to be as tight for a hair braid or for a rope. Let's say you're trying to get like a nice rope. You get a bunch of fibrils together, weaved together, and the more you put in there, the stronger it is. Now the rope's doing something. Well, it turns out that there are like 100 different types of genetic mutations, with a subset of few that have been well studied and a lot that have not, that affect the way that collagen is produced. And what happens is that you don't get like a nice, clean collagen triple matrix. It's frayed in some way. So this is an AI-generated figure, and it's overly simplified for teaching purposes, so it's not something we'll publish. But just to kind of teach you the point that healthy, normal collagen fibrils has a really strong, nice, interwoven triple helix. And in EDS and hypermobility, it's frayed. The fibril structure isn't well cross-linked. It's, all over the place. And the result of that is decreased tensile strength and increased laxity. So instead of having these nice triple helices, they're more disorganized and unreliable. Is this helping you guys so far, understanding why we're talking about it, and molecularly, what's going on? Now, clinically, if you're hyperextensible or hypermobile in your joints, you're also hypermobile in your fascia throughout the entire body, including your airway, your gut lining. What's that? Okay. And, it's severely underappreciated. People with hypermobility can be categorized into two kind of domains, symptomatic and asymptomatic. Asymptomatic means you do the test and they're a little bit more mobile than other people, and that can be 10 to 20% of the population. And then you have symptomatic hypermobility, in which they're having a host of issues underneath the surface. Musculoskeletal problems, so they get injured easily from sports. They can have orthopedic deformities, pectus excavatum, scoliosis, club feet, hip dysplasia, and also systemic issues like fatigue, orthostatic hypotension, GI issues, urological prolapse, bone fragility, blood vessel fragility, organ fragility, skin fragility, delayed healing, and things like that. You guys with me? So important to recognize this, because if you don't, you can get yourself into a lot of trouble. Here's a patient that came to us with low tongue posture, wanting to release his tongue tie. Open up for me. Very, very good. Lift up your tongue up to the front two teeth. Good. Show me your suction hold. Good. And then put your tongue into the back of your throat like you just did. That's amazing. Well done. Bring it up. Do it again. Good. Suction hold. All right. And tell us your problem with the tongue. You can't get it up, right?
Yeah, I can't get the back up all the way.
Gotcha. Okay. So I believe him. He can't get his tongue up. I wholeheartedly believe him, and he's suffering, and he's hoping that tongue tie is the solution to all his problems. But it's not. It's not. And it's not right to subject this person to a tongue tie release and say, 90% of patients do better. Oops, you were one of the 10%. Because you can see that this is set up to be a suboptimal case. You guys with me? Yes. I said, lift up your tongue, and it was going. And he just did it. They do it for you. I'll show you another case in a minute. Yeah, if people can do this, I don't know if you need a tongue tie release. I don't know. What do you guys think? Can we get a consensus on this? All right. So if you're having a problem with hypermobility, it's a disorder, that's 3 to 10%, which is a lot. And these people have decreased quality of life, musculoskeletal issues, chronic pain, fatigue. And so we have to recognize that hypermobility is not like a skin or joint problem. If you have hypermobility in your joints, it's not that I'm not doing it for your joints for your tongue tie, but if your joints and your skin are that mobile, probably the connective tissue in your entire body may have a problem, right? And so it can really affect every system. And it's so rewarding to diagnose these patients. It's so fun. They've never heard, they don't even know themselves. And as soon as you tell them, it's just everything kind of clicks. So here's a patient who came with TMJ issues, sleep issues, morning headaches, And she had something that was similar to like thoracic outlet syndrome. So let me play this video for you, and we'll talk more about it. Could a tongue tie cause numbness in the arms, especially in a patient with hypermobility?
I'm hypermobile in my jaw, in my legs, and my hands. When I lift my arms, they start tingling and go numb. And recently, in my back, it's just been going numb on the left side, even when I'm doing the dishes or just standing at work.
Oh my God.
And I'm sure you're wondering, how could this even be possible? From a tongue tie release, let's break it down. What she's describing is called thoracic outlet syndrome. This is when nerves and blood vessels that travel from the neck into the arm get compressed between the collarbone and the first rib. It can cause numbness, tingling, weakness, even pain in the arms and shoulders. In patients with hypermobility, the connective tissue is already looser and less supported. This can cause forward head posture and shoulders that are rolled forward. In addition, a tongue tie can also cause restriction not only in terms of limited tongue mobility, but also in the fascia that travels through the floor of the mouth into the neck and diaphragm. This restriction can draw the head and neck into a forward head posture that sets up a compression pattern that can exacerbate these symptoms of nerve and blood vessel compression that we see in thoracic outlet syndrome. When we release that restriction, you can see the difference immediately. The tongue moves freely, the head, neck can come back, the shoulders relax, and symptoms improve.
I felt like a release in my belly. Everything was tickling it felt relaxed. Wow. I felt like my shoulders relaxed. Oh my God.
Really? All of that from a tongue release?
Look how far back I can go.
Many people often ask me, what's the relationship between tongue tie and hypermobility? And the answer is that patients with hypermobility are sometimes much more sensitive to the effects of a tongue tie. In this case, a simple tongue tie release helped this patient with posture, breathing, and even symptoms of thoracic outlet syndrome. It's really amazing to witness how connected every part of the body is. I'm Dr. Soroush Zaghi. All right, so let's take a look at this case and understand more. There's two components here to her, this is her post-op, but there's two components here, okay? You can see that she's actually like physically restricted. You guys see that there? And so what this is doing is that layer where you're supposed to be mobile isn't, and the deeper, it's too tight on the top and too loose on the bottom. So again, we talked about the superficial fascia being a glide layer and the deep fascia being a load-bearing layer. So in her case, the load-bearing layer was too weak, and the part that's supposed to be elastic is too tight. So just releasing that can help. But again, the release is mucosal and superficial fascia only. We don't get too deep. Let's take a look at what she says later on when we're starting to help treat other aspects of her hypermobility by sending her to, I'm working with Cynthia Butler, who's an amazing physical therapist with a lot of experience in this area. Welcome back, Claire. It's been 2 months since your tongue tie.
Yes.
And 1 month since your septoplasty.
Yes.
Tell us about your journey.
Since my tongue tie release, I have had better mobility, better breathing. I feel like I can fill my lungs all the way up now, so that's been a huge improvement. My thoracic outlet syndrome, that's what it's called, right?
Yeah.
That's gotten better. So there's just been a lot of improvements overall.
Fantastic.
Yeah.
So we released your tongue tie, we put it together that you had thoracic outlet syndrome, kind of blew your mind at the time.
Yeah.
But since then you've had a lot of improvement and progress. Is that right?
Yeah.
Tell us what you've been up to.
I've been seeing a craniosacral therapist weekly. It'll probably taper off in the future, but after seeing him, paired with the tongue tie release, there was one day I woke up and I just had a sudden sense of change in my body. I felt like all my limbs were 2 inches longer. We went to a restaurant, and when I reached for water, I almost knocked the water over because the glass hit my hand earlier than my brain expected my hand to touch it. We went to a market, and I was like tripping all over the place and bumping into things, and I just realized. So these are good, but it's also kind of a little bit drawing awareness to that they don't integrate as well, right? They don't have good proprioception. So the post-op physical therapy component is very important. That I really needed to work on my stability because I have all this newfound mobility. So it's been a journey, and I still have things to work on moving forward, but this has been a really great start. So,
Amazing,
yeah.
amazing.
Thank you so much.
You got it. How much did the tongue tie play a role in the whole improvement of things versus the physical therapy, or was it really a combination?
I think the tongue tie is like the main thing. I've had physical therapy on and off for my whole life, and there was never really any improvement through that. So the fact that I was able to get my tongue tie released, that has allowed me to go into doing things like physical therapy and have actual improvement this time. So I couldn't have improvement without the tongue tie release.
Fantastic, fantastic. Let's take a look at your tongue, okay? Go ahead and open up your mouth for me. Lift up the front 2 teeth, and it looks really, really nicely healed. Congratulations.
Thank you.
So super stoked for you. Yeah. Show us your mobility one more time. Just a lot better. Before you go numb, and now you're feeling maybe a little bit, but not as much. Is that right?
Yeah, I still need to work on the strengthening my muscles in my back and, all through my core, so I'm walking the right way, not locking my knees, that kind of thing that's associated with hypermobility. But I definitely can move a lot easier with much less pain, much less restriction, and overall, there's just been a lot of improvement. I don't have air hunger episodes anymore. I was dealing with those every single night after work, and they would last for several hours, which only builds up anxiety because you feel like you can't breathe. And now I just feel like I can,
breathe.
Yeah.
You can breathe. Amazing.
Yeah.
Amazing. Well, thank you so much. I think there's a lot of hope to a lot of patients out there. And hopefully we can use this to educate the providers on understanding the importance of recognizing signs of hypermobility so you can optimize the outcomes in your patient.
Okay, so for this patient, I did a septoplasty on her, upper lip tie, tongue tie. Palate expanders are really good. Oral appliance therapy, not so good. And jaw surgery, also really complicated in these patients. I'm sharing this case, to say that this is a special population. Not saying don't do tongue tie lessons in the population. It actually can really help them a lot. But also, they need a lot more adjustment and help from a physical therapy perspective, and the physical therapist should be someone who's hypermobile aware, because the therapy is very different for someone who's rigid versus someone who's hypermobile. So this was her case, all right? And when you're going through the tissue, I would recommend you keep it mucosal and fascia, superficial fascia, and avoid the deep fascia to the extent possible. Here's another case. This is a case of UARS. So what we see in sleep is that there's different patterns of obstruction. One pattern of obstruction that you can have is the level of the soft palate, and this is what the collapse looks like. Okay, this is without CPAP. You see the tissue is just so redundant there. And then this is after CPAP. Okay, so there's just too much increased tissue laxity causing a collapse. Sometimes this can be improved by stretching out the bone structure, stretching out the jaw structure with palate expanders and jaw surgery. However, there are other cases where you take a look and the airway's fine. There's no room for palate expansion. There's no elongated soft palate. The septum is good. So what's going on in these cases? And what we observe is that it's the hypermobility. These patients will do well from limited soft palate remodeling and sleeping upright and different forms of physical therapy. Let's show you another case. This patient came to me, 14 years old. He had torticollis as an infant. He was hospitalized for dehydration, said to be double jointed. He had sleep apnea, and he was using a mandibular advancement device, okay? Yeah, especially if you're doing orthodontic treatments, trying to pull out the lower jaw, you can make them more stretchy. He had cyclical vomiting, abdominal migraines, fatigue, just always in pain. It's a pediatric patient. So I took a look at his tongue, and here's what he can do. I said, lift up your tongue. I said, nope, it's okay. So he's lifting his tongue all the way up into his palate. And then I do the Baton criteria, and it turns out that the mother had hypermobility, he has hypermobility, he had a Baton score of 9 out of 9, and we'll review that in just a few minutes here. Upon further physical examination, he has big tonsils, He has large turbinates, so certainly low hyoid. So this is not going to be like a tongue tie case. Certainly we can help him with his tonsils, adenoids, maybe palate expanders, but not going to do any tongue tie surgery. Now let's say we take him to the operating room and we're doing the tonsillectomy. As part of the tonsillectomy, typically you extend their head backwards. But these patients have increased tissue laxity and are at risk of something called craniocervical instability. Anyone heard about that? Yes, you've heard about it? Okay. So craniocervical instability means that you get like whiplash injury, okay? And then you tear the ligaments in your spine, and then now someone who's mobile can barely keep their head upright, okay? And then they get stiffness everywhere else to kind of hold it upright. Sometimes these patients even need to do like cervical fusion. So before we even go there, I send them to a physical therapist who's educated about this, and so they sit there and talks to them about how the cyclical vomiting is a manifestation of dysautonomia, how he has POTS, and he has craniocervical instability. And it's important to be aware of that because a lot of physical therapy, you're stretching. But for patients with hypermobility, you don't want to do a lot of stretching. Rather, you want to do load-bearing exercises. You want to give them compression stockings. Compression stockings alone can really help them return their systemic volume and function better and not feel so lightheaded. So excellent paper that synthesizes all the research in hypermobility. It's an important framework to understand. For your purposes, you have to understand that it's a collagen problem and there's abnormal collagen. And these patients need different types of treatment. They don't need to stretch too much, okay? You want to avoid stretching with oral appliance therapy because it increases the tissue laxity. When you do jaw surgery, the joint position can be unstable. You don't want to do too much like yoga exercises unless it's more core strength mediated. And you want to do more load bearing. And the physical therapist, if you're stretching, it doesn't quite work and actually makes things worse. So this is Tom Myers.
So I am here at a lecture in St. Gallen, Switzerland, and I'm learning about hypermobility from the man himself. So no pressure. Teach me what I have to know about hypermobility, my friend.
So many people are Vikings, the opposite of hypermobile, and most of the treatments that we have had in bodywork are for Vikings or tough-toned people. We are learning so much about EDS, LDS, and those kinds of, and what I learned from either Rolf was totally inappropriate for these people. What you're doing is searching for little islands of tension by which they hold together the whole of the body. And when you let go of these little islands of tension, you then need to train them for tonus over the whole body, which is a lot of standing poses in yoga and what would happen around the jaw. You people, I'm sure, know better than I. But building balanced tone in the body is what you need to do.
Amazing, amazing. Stay up there 1 second, okay? So the important point here is that regular physical therapy often makes these patients worse, okay? So they're gonna be a little skeptical. They're a little bit burned out. Are there certain recommendations, like a list of things that you tell these hypermobility patients to do or not to do in their daily lives?
Don't go to yoga class. don't
yeah, so like surfing, bodyboarding, extreme sports, what else?
They have a whole body thing that they can wear.
Yeah, compression is really good, but thank you so much for that. Big round of applause for Dr. Tom Myers. Good.
So we're taking a fresh look. There's some physical therapists in the crowd here. Anyone want to make a comment? Dr. Neal, do you want to make a comment at all? Or hypermobility? No? Anyone make a comment about this? Yes, please.
I am going to show that there are
Yeah, please. Give her the microphone.
There's a craniosacral therapist out of the Uploader Institute who specializes in EDS, and she also teaches other craniosacral therapists about working with EDS because, as with everything that we do with an EDS person, craniosacral therapy techniques have to be geared specifically to the EDS population and to the type of EDS. And there are 12 different categories of EDS.
Absolutely beautiful.
And there is a large proportion of EDS people with tongue tie, but it presents very differently.
Agreed, amazing. Any other comments? Okay, Dr. Neal, yeah.
Yeah, I'll just focus on my narrow aperture of the floor of the mouth and say in all the range of hypermobility EDS patients that I've worked with, although there's like a lot of intricacy to what you could do, what I've found is when these 4 key areas in the body, the floor 4 are released, and often it's the thyroid, it can bring this shift in tone to the ligaments, especially the thyrohyoid ligaments, and create change there that can not only free up tension in the floor of the mouth, but enhance tone and also create some compensatory changes that counteract the laxity. So what I found is through some of that it's really great to have a system like craniosacral, but mine focuses on calibrating the parameters viscerally that shift tone to allow the brain to create homeostasis versus loosening fascia, which doesn't work for these people.
Perfect. Thank you so much. So we learned that it can really affect people in many different ways, and it takes a different approach to really being able to treat these patients. One of the most important things I see is that they're often like misunderstood. So, they can be labeled as difficulty with concentrating or ADHD or, going to the bathroom a lot or just being kind of weird. But when you understand that it's actually a condition of EDS or giant hypermobility syndrome, you can have much more compassion and really help these patients. Like the doctors here said, there's many different types of EDS. Each one, exists on a spectrum. We have tier 1, which reflects increased flexibility, and they're just, maybe perhaps asymptomatic. Tier 2, where they're having some GI issues, orthostatic intolerance, fatigue. And then tier 3, where they're having multi-system involvement, including autonomic dysfunction, mast cell activation, and other issues. Many different types, 13 different types, and which is beyond for our purposes. But for our purposes is like, what do you need to know? What you need to know is that, first of all, the tissues are more fragile. So if you're doing a jaw surgery or you're doing a throat surgery, you have to be aware that the tissues are more prone to getting easily injured, or the sutures may come out, or other things like that. Other things that we should know are about how to assess for it. And so there's some certain questions you want to ask. Do they know about connective tissue fragility disorder? Do they sprain or injure easily? Do they experience dizziness, GI issues, or temperature intolerance and get really cold? And if you start to hear these things, or if the abnormal wound healing, you want to be aware. And then especially during the surgeries, you don't want to extend their neck backwards because you can cause trouble there. You want to have more neutral. Like we said, you want to avoid oral appliance therapy. Palate expansion, especially if it's maxillary skeletal expansion, is going to be better than dental-alveolar, which just kind of tips the teeth. You can get a lot of dental tipping in these patients if you're not doing a skeletal approach, because they have a lot of flexibility, and then it relapses once it's out. What else can we say? All right, how to screen. All right, so the way that we can screen just kind of in your clinics is using the Baton criteria. So we'll have a demonstration of this. Anyone know that they're hypermobile? Anyone know that they're hypermobile? You're hypermobile? Do you want to come up and demonstrate for us? No? No, we got a no there. No worries. No worries. Anyone else? Okay, you guys can try this yourselves. I didn't see any show of hands. Did I see one? You got it? You want to stand up and show us? All right, so you can stand up right here. Anyone else want to come? Give her some company. All right, so just go ahead and everyone just, kind of put your hand flat like this and kind of raise up your pinky and see if it goes up beyond 90 degrees. Let's see yours. Yours does? Yeah, come on up. Come on up. Come on up. Come up on the stage. All right, so hand flat like this. You have it a little bit, doctor. Maybe we'll diagnose some asymptomatic EDS in here, huh? All right, come on up on the stage. What's your name, doctor? Elise? Elite. Thank you for being here. Show us your pinky. So yeah, so you can see it goes beyond 90 degrees. Anyone can match this or beat it? All right. You have it too. You want to come up as well? Yeah, come on up. Let's do the thumbs. So for the thumbs, you stretch down and back and try to get your thumb back this way. And she can do it no problem, huh? Yeah. No. Okay, let's see yours. That's the other. So that was, sorry, the pinky one was like this. It's flat this way and up. Oh, you got, so easy, no problem, right? All right, so elbows, can you extend beyond? Yeah. All right, we're seeing that, you guys, all right? And then you do it on both sides, okay? And then the knees, can you flex your knees backwards like this? Yeah, no problem. Okay, look at that, all right? Hyperextension, and can you touch the floor easily? No problem, okay? So it's one on each side, so if you try it on the right side, left side, that's 2 points, 2 points, 2 points, 1 point, be 9 out of 9, okay? And then there's certain questions that you can ask. So can you now or ever place your hands flat on the floor without bending your knees? Can you place your hands flat on the floor? Show us, do you mind? Okay, so that's a yes. She's wearing boots, no worries. Okay, can you touch your thumb to your forearm? That was a yes. As a child, did you amuse people with this, like doing splits, or did you have that? Maybe, maybe not? Yeah. Did you ever dislocate a shoulder, a kneecap, or more than one joint? No? And do you consider yourself double jointed?
Yeah, I can also do, yeah.
You're okay? Yeah.
I could do the same thing with my shoulder.
You can do the shoulder too, all right? So it's just important to know about this. There is a whole diagnostic checklist, and we just want to thank you guys for participating. Any comments about your condition? Did you know about it?
I just knew I was always like...
Okay, so asymptomatic, but you're going to... You had tongue tie as a result? Okay.
When I was 20.
You had a tongue tie as well, and it helped you a lot?
But without myofunctional therapy.
You did with myofunctional therapy, tongue tie release.
And now I have a little scar, but it's with a breeder, I don't know to say like a...
Oh, you have a little scar? Okay.
But it's okay.
Okay, looks good. Looks good. All right, so fantastic. Thanks again for participating, all right? So the diagnostics is really complicated. The key takeaways are just to know that it exists, to kind of screen for it, and to be aware of other systemic comorbidities. The ones that you may recognize are problems with autonomic dysfunction. So basically, if your extracellular matrix is too loose, there's not enough force back on the blood vessels, and the veins can just kind of drag blood, and that can cause migraines and headaches and dizziness and things like that. It can also cause problems with temperature regulation, feeling hot or cold. There are mast cells inside the superficial fascia, and there are some people who have easy activation of their mast cells, which is like a very severe allergic reaction type of a thing that can make them feel extremely unwell. It can cause GI issues with dysmobility, reflux, irritable bowel, easy bruising. It can cause airway issues. It causes airway collapse, soft palate elongations, and our part is to be able to understand this and get this to experts who can appreciate it better. Let's hear from this individual about how a lot of different things can be interrelated.
Do you know about the connection between hypermobility and pain, fatigue, and autonomic dysfunction? A new study shed light on how significantly the quality of life is affected in women with hypermobility and Ehlers-Danlos. What really struck me was 99% of the women in the study experienced pain, and autonomic dysfunction was worse than in people with MS, lupus, and rheumatoid arthritis. As reported in the study, and what I see in my practice, is hypermobile women also experience depression, fatigue, and migraines. These associated conditions, MCAS, POTS, and dysautonomia, often go undiagnosed, leaving patients without a clear treatment direction. If you want to link to the study, comment POTS below.
All right, so we're seeing its effects on POTS, on autonomic dysfunction, on GI issues. Anyone have any questions or comments or want to share anything? I don't suffer from this personally. Was this interesting to kind of hear about? Okay, something important for you guys to understand. And so, the management must be individualized and staged. You want to avoid aggressive interventions. Interdisciplinary care is essential. And it really takes you back to the structure-function debate, such that it's neither structure nor function and behavior alone that determines growth. Form and function are truly a continuous feedback loop, and we would do well by understanding and recognizing that. We want to promote exclusive nasal breathing, strengthen internal muscles of the lips, promote ideal resting oral posture. One other thing that I'm super excited about that I wanted to share with you is my work with nasal airway remodeling. You guys may have heard about nasal valve treatments, but we've come up with something patients are really loving it. It's called the Breathe RF nasal airway remodeling procedure. If you see people with like nasal valve collapse and they're sensitive to it, especially in these hypermobile patients, they can really benefit. It's something you can also offer kids. I'll play this video for you because it could be a good opportunity for you or some of your patients. Nasal airway remodeling. This is the nasal airway, and this portion of it is called the nasal valve. The nasal valve is the junction between the upper lateral cartilage and the septum. It's the narrowest part of the nasal airway and the most important for regulating nasal airflow. Even small changes here can make a big difference in breathing. Here's a patient we treated with nasal airway remodeling. Nasal dilators, intake magnets, and strips can all help support the nasal valve, but when it's a structural issue like this, we can offer a longer lasting solution with nasal airway remodeling. So let's show you how it works. Okay. You see the difference?
Yeah.
You feel it?
Hallelujah.
Yeah. All right. The Breathe RF nasal airway remodeling that you saw here is a technique we developed right here at the Breathe Institute. Compared to other approaches, it's faster, more precise, better tolerated, and often results in less swelling. That means more airflow and less recovery time with results that last. It's a simple, in-office, one-time treatment for more stable airflow night after night without having to rely on strips or dilators. Strips and dilators are a great place to start, but if you already know they help and you're ready for something longer lasting, nasal airway remodeling might be the next step. I'm Dr. Soroush Zaghi. All right, yeah, so it's super cool. You can see this is the before, immediately after, and the breathing a lot better. We also want to let you know about our book that came out, Goodbye Tongue Tie. It can really help with desensitization and help you guys be able to do these procedures on young children. It's on Amazon. I think it runs like $10 or $15. And as we wrap up, I want to remind you guys that the truth is only the truth for a set amount of time because the truth is always evolving. Remember that when we grew up, they taught us the food pyramids. Remember this? You have to have like 6 servings of grains. And remember this? And how much? And then now it's like upside down, right? And so we really welcome that. And we encourage you guys to keep learning, keep contributing, keep observing, keep writing. And that's really the way we're going to move forward. For those of you guys who are new to these concepts, we have a one-day course called Breathe Foundations. If you have someone who's not really interested for the full experience of the Breathe course, this can be a good opportunity for them. If they just want to get a sense and you want to get them on the same page so they can understand this. And for those of you guys who want to learn more in detail, 4 days, in depth, this kind of style, we'd love to have you at the Breathe course. The next one is in March and July. We also have great myofunctional therapy courses. But otherwise, I want to thank you guys so much for this opportunity and take any questions.
Soroush, I have to say something.
Yeah, sure, please.
There's been something on my mind for about 40 years, and you just cracked it. I just figured it out. So when I was 20, one of our fellow black belts says, I got to show you something. He takes me to a Pizza Hut, and this guy that works there full times, he's completely out of shape, and he starts doing stuff that only a world champion in karate could do. He'd raise his leg without any training. We're definitely jealous of him. I mean, we were dying watching him. A year and a half later, somebody walks in, 150 pounds less, frail, near paralysis. And my friend says, by the way, that's the same guy. We're trying to figure out how a 20-year-old got stroke. He almost died. So now, I believe, based on what you said today, he had other issues. Because I'm like, what are the chances that somebody can do these great feats that I've never seen before, and now I'm just, thank God I can do what I can do, and we had to bring the stick down here for him to jump over it. He was trying to recover from
Poor
paralysis.
thing, poor thing.
And I think you just
it
explained that to me because I was always
I'm
a mystery.
so glad that
How does a 20-year-old get a stroke?
Wow, yeah, and it could be the
So
missing
thank you
piece,
for
so thank you for that. Yeah, amazing. Any other questions or comments or anything? What do you guys think? Give me some feedback. We appreciate it.
All right, you got me intrigued because I looked into this radiofrequency ablation a few years ago, and I asked all my ENTs around. They said, no, we don't do this kind of stuff, and it was being done back east. That's what the nasal valve surge is. You're putting something in radiofrequency, it's shrinking those things. Can you explain that?
So you're asking about the nasal valve remodeling and what it's doing. So it's basically heat energy controlled, not too hot, not cautery, just like warm enough, and it ablates the tissue, it tightens the tissue. Kind of think like soft palate remodeling, but for the nose. The Vivere is one approach to do it. We've refined it to have it be really effective with different settings and tools, and we're getting like really good results with it.
Do you actually put a probe into the turbinate and the nasal valve? And then
it's all superficial to the tissue. It's superficial to the tissue.
Okay.
And it uses heat. It heats up the tissue, and it causes it to warm without burning.
Okay, is this something that it can only be done by an ENT because?
Only done by an ENT.
Okay, so how do we get our ENTs in?
Yeah.
Now, you developed this? Do we have to go get them to come and get it from
There's
you?
a different version. It's called Vivere. That's like more mass available. But this version I've really refined because I've had patients who've had the Vivere procedure with limited results. And so I like took it up like 10 notches, and you get less swelling, and it's like more effective. So, you know, we're still exploring it, but we have like 100 patients, and we're going to hopefully publish it soon so others can learn. Yes. Oh, yeah, it's coming.
What's your red light therapy protocol?
Yeah, so we're currently using the MLS, and the way that we're understanding that the red light works is that it shines light onto the mitochondrion, and it helps to just give them more energy. And by doing that, it enhances, you know, cellular function and recovery. I was really skeptical about it at first, but having gone through my own physical therapy, I would get like neck and shoulder tension after like workouts, you're carrying the babies, and when you apply it, it like relaxes it, it feels better. So we're exploring it, and we're seeing how we can use it to help our patients, whether it's after tongue tie release or after like tonsillectomy. Patients are in a lot of pain after tonsillectomy. Can we use red light therapy to minimize the pain and need for narcotics and other things and steroids and things like that? And you know, patients so far seem to appreciate it. Yeah.
So you just have a wand and you're just putting the light on?
There's the wand, and we
right
also have like a whole body,
body.
like light for our post-surgical patients. Let's say you have like jaw surgery or septoplasty, and you know, we're exploring it.
Quite. And then I did click on the link and I didn't see the visual guide in that same link on your paper. Is that?
Yeah, let me, yeah, if you have to go down, there's a link.
Okay.
So go to the paper, try it now, tell me, make sure.
Okay.
You go all the way down, and then there's a link that says supplemental.
Or if you land on the IGA1 page, there's like 4 buttons, download, book cover, and there's one that says supplemental.
I do want you to find it. So
Down,
do you see
down,
it? It's like
down, down.
additional information, something like that.
See the article. It's after your citations.
Is it
theoretically.
additional information? Is it after the citations? You can check, Layla.
I just clicked the link, so it says mdp1.com on
Yeah, and then you scroll down, and then under like additional information or supporting information, it's like a hyperlink. That'll take you to it. Other questions? Yeah.
I have one more.
Yeah. A physical therapist. Physicians don't understand this. Yeah, it's craniosacral therapist, physician, body worker who understands it. Because just getting into small things, like wearing tighter clothes, they don't need to wear baggy clothes. They should always wear tight clothes to kind of keep them together. Okay? Undergarment, like compressions, can help them a lot. Oh my God. Keeping them hydrated. And then for the sub things, like let's say they have mast cell activation, there's medicines you can take, but specific doctors just have to be aware of it. And I put a lot of the recommendations in the slides, so in terms of like what medicines to give and how they work and things like that, so you can take a look. Yeah, but it has to be someone who understands it. The people who understand it are very passionate about it. Yeah, huh?
Yeah, there's this Instagram person, her name is Bendy Pediatrician. She has a lot of good stuff for kids. It's called Bendy Pediatrician. You could do this all ages, this procedure, in kids too. Yeah, so when I do tonsils, adenoids, I also open up the nasal valve. You can also remodel the septum a little bit.
A lot of our patients travel
Yeah.
and leave the same day, so we have a lot of patients who do
Yeah.
this procedure same day go home. So
Other questions, comments? Yes, please.
What device was it that you said you use?
For what is it?
What device do you use for the radio frequency?
It's called coblation.
Coblation. So you use like a Eris wand? Or
it's just different.
Or what's the company? You're developing it now?
Yeah.
Oh, okay. Okay. I'm an ENT. I'm a DO.
Fantastic. Okay.
And I have started doing the radio frequency ablation because I was placing those stents to help with the sidewalls, and gosh, they just didn't seem to help as much. And I found good results with that, and I'll use an Eris wand.
The Alar stents, yeah.
The Eris wand that you would use for coblation of the turbinates?
Yeah, you just put on the nasal valve.
Yeah, yeah.
Good. Any other questions? All right. Yes, one last question in the back there.
Yes, not regarding this lecture, but regarding younger kids in therapy and when you've done expansion, tongue-tie, tonsils, adenoids, and they're still mouth breathing. Is that just a habit that...
We see these cases. We see these cases. It was really a case-by-case. Sometimes the palate expanders were dental-alveolar, not palatal. Sometimes it's anterior-posterior. Sometimes they have low tone. Sometimes they have hypermobility. So I'd look at all those different dimensions. But I would for sure do the Baton criteria and check for hypermobility. You want to look for low muscle tone. Yeah, sometimes the jaws are still recessed. But I know I appreciate the question because you come from a place of caring. You really want to help these kids, and you're like, what is it? Sometimes it is the nasal valve, but you really have to take a look. Yeah.
Thank you.
My pleasure. All right. Thank you guys so much. It's been great to be here with you. Thank you guys for attending and participating, and we'll see you at the next event.